Okay, good morning, ladies and gentlemen. If we can come to order, please. Okay, thank you. Good morning, ladies and gentlemen, and welcome to CCAM's board meeting in April. This is a board meeting in public, and it is my first meeting as chair. And I'm really fortunate. I joined as chair at a point in time that we celebrate the fact that we have left special measures. And I would like to thank all of the executive and all of CCAM people for all of the efforts that they have expended to make sure that that has happened. It is really excellent news. I welcome all staff and members of the public and other stakeholders who may be watching today. I just want to say a few welcomes to Nick, our new Chief Digital Officer, to say thank you to Stephen, who had the role until recently, and thank you. You're very welcome in joining CCAM. Before I go on to our major proceedings, I do want to make a broad statement. Which suddenly disappeared. If I could start, I'd just like to say a few things because we know that this week there has been a lot of media coverage about CCAM. And I would like to begin by providing assurance that without going into specific detail, both of the cases highlighted in the media coverage were properly investigated, including through external investigation where necessary. And I want to give assurance to CCAM people and stakeholders that appropriate action was taken. As an organisation, we know that we have more to do to make CCAM the best it can be. But the perception given in the media that CCAM as a workplace and of the care we provide to patients was wholly inaccurate. The leadership shown by Simon and the executive team during the past 3 years has resulted in measurable positive change. As chair, I think it is important to share with the board today and the public the considerable level of support that I and the executive team and the chief executive have received from across the organisation. Collective letters of support have been sent and shared by all members of the senior management group and the lead and deputy governor, plus dozens of individual messages of support from across the organisation have been sent to Simon, the executive, and to me. And I particularly want to highlight a heartfelt letter I received yesterday from more than 20 of the operational managers, giving their wholehearted support to Simon and the very real difference he has made since joining CCAM. We now need to think through the next steps that we take. But I know that Simon and the whole leadership team will not let this distract from continuing to make the improvements we want and need to make. What we're trying to do here is make CCAM the best place to work to ensure that we deliver the best care for our patients. This is a fundamental change journey that we are 100% committed to, and we must succeed. That's all I want to say on this issue. There are opportunities later if people want to ask questions from members of the public, but I'd now like to start the formal board proceedings and ask, are there any conflicts of interest that need to be recorded or reported? Unless I hear anybody hold their hand up, I will assume no. I think we only have one apology of absence, and that's from Subo.
Correct.
We now go on to the minutes of the meeting in March, and can I seek approval for those minutes and that they're a true and accurate record? Can I ask somebody to propose? Yep. Paul, thank you very much. So we can take those as read. Peter, can you say anything about the action log, please?
Yeah, Chair, the actions on the log have been covered by recent committee meetings as reflected in their reports to the board today, and there's one action that's on the agenda later.
Okay, unless I hear the opposite, I assume that's taken as read, and we will follow up as we go through normal proceedings. Again, you hear briefly from me, there is the chair report, which is included in the information that is available to you. I just want to make 3 observations on this. We're at the end of April. April is an interesting month because it's an opportunity to look back and look at the performance of CCAM over the last 12 months, but it's also an opportunity to look forward and to be confident that as an organisation we are managing all the risks that we are aware of, and that we are managing the organisation in a way that ensures that we deliver the best patient care and that we provide an appropriate environment in which our people can flourish. So what you're going to hear today, and where we'll be looking for the board to have appropriate levels of assurance that we have put in place the right strategic framework to navigate our way through the next 12 months and beyond, as I said, to ensure that we deliver the best care possible. And so your observations as a unitary board and to get assurance on that will be important, and I'll return to that question at the end of today's meeting. The other thing I'd mention is very grateful that we had a meeting of the Council of Governors last week. They reinforced the need for CCAM and the board to ensure that we continue to make good progress in all that we are doing. And the only other thing that I would bring to your attention is that we have now, or the council has appointed 2 new non-executive directors who will be joining the board later in the year. So that's all I really want to say as my chair report. The important thing, and I reaffirm this, and I will continue to reaffirm it, is we have made considerable progress in improving the level of service that we provide for patients. We want to build on that and be confident that it is sustainable and sufficiently resilient over the coming years. And we recognise the significant challenges that the NHS faces, both in terms of resource constraints and the need to improve productivity. We are a key system player, and I would say to all stakeholders out there that we are very much up to working with our partners to ensure that we deliver the best for the national health and all the patients that it serves. So at that point, I will turn over to Simon as Chief Executive Officer to give his report.
Thank you, Michael. So I have the pleasant task this morning and looking back on the year that has just gone. And it is one that I think we should feel brightly proud of in many things that we have done. I'm not going to assiduously go through all of those points, but I am going to draw out a few that I feel we should be particularly proud of. The first, and it is a core deliverable, is our delivery of the C2 mean target, the 30-minute response target. That has been a struggle for the ambulance sector across the country. We were one of a small number to achieve that. We hit our expected time of about 28.5 minutes, almost precisely as we predicted. And that is a really good place to start a reflection on the year that has just gone. It is a testament to the dedication of all of our senior leaders across the organisation, because we do work in a highly devolved system and we rely upon people doing the right thing out of our sight, away in their parts of the patch, and day in, day out, they do that, and they do that with excellence. The particular point in relation to clinical care that I want to highlight, however, is our cardiac arrest report. Not only was the report commended as one of the best in class, more importantly, I draw the board's attention to paragraph 12 of my report, which demonstrates that we delivered a cardiac arrest survival rate of 11.5% for the patients that we saw. And that is 307 people who had their lives saved by this organisation, who otherwise might not have been with us. It was the highest rate recorded by an English ambulance service and a 2% increase on the previous year. That said, we should not be complacent about either of those figures. Firstly, the C2 mean is not the actual standard that we should be aiming for. It is the 18-minute standard. That was set for very sound clinical reasons. And we have to retain the aspiration set out in our strategy that during this Parliament we recover to that. And I remind everybody around this table and everybody listening of the importance of the transition that we need to make. Put simply, when you need us, we will be there for you, and we will be there for you faster than we are at the moment. But when you don't need us, we will ask to work with you to find a different and an alternative disposition that's still clinically relevant and appropriate to your needs, still safe for your care, but doesn't involve us in sending our most precious resource, our most expensive resource, which is an ambulance. The evidence is compelling and remains compelling that in the increases that we've seen in demand, only a fraction of that demand needs an ambulance. So, some other things that I would like to highlight. Firstly, I think our people can only do what they do if they feel the organisation is a good and appropriate and safe and positive place to work. We know that from our staff survey results this year, we made a signal improvement. We are going to reflect on that, so I'm not going to say too much about it, otherwise I will end up talking about that to the extent that Janine won't have anything to say. But what I will reflect on is that we were particularly pleased to see the scores in respect of morale across the organisation. For me, morale is a really powerful indicator of people feeling positive about the place that they are working in, and we know that there is more to do. To do more, we need to change the way we structure the organisation, and so the work that Jen and her team are doing to move us into a divisional structure is really important. One of the key things that the staff survey touches upon, reflects on each year, is this sense of, can I make a difference in the job that I have? Can I make a difference? Not, does the organisation make a difference to me? Can I make a difference? Do I have agency? And we know that our leaders are hungry for more meaningful autonomy, and that delivering that in the year ahead is a really key outcome for us. We know too that in the year ahead, as Michael has already said, we've got more to do. The staff survey indicates that there are far too many concerns still from people, particularly, for example, in respect of violence to staff at work. That is an issue for us. It's an issue for the sector. We know too that in our efforts to improve our diversity, we've got some pretty fundamental challenges. For example, the board seminar that we had on EDI recently highlighted the lack of representation of women amongst our senior management group, and that for me is a fundamental priority alongside all of the other things that I've already described. It's important to say a big thank you to our volunteers. Some of us were in the room for the volunteer conference just a few weeks ago now, and again, I would pay tribute to the work that they do in their communities. As the conference made clear, they are often the first people that patients see on scene, and the work that they do to, in their own time, support those communities is truly remarkable. And I would like to take this opportunity of looking back to say thank you again to them. They are too hungry to do more, wants to do more, and we will in June consider a review of that we've had done externally of the current state of our volunteer workforce and what they want to do and how we're going to support them doing that. And I look forward to that debate and welcoming them, some of them, to the board. Michael's already alluded to the fact that the NHS is challenged, and we will spend time thinking today about have we got the balance right. And I remind the board of the comments we made at a recent board seminar. We will need to have in our minds this balance between delivery, quality and efficiency at all points in our conversation. Have we got that right? In easy times, it's relatively straightforward to have that conversation. In the times that we are now in, it's going to be a hard thing to reflect on. One example for us to think about, we've been asked to go further in our C2 mean performance this year. It's right that we've been challenged to do that. The board will want to reflect on how much risk that plan contains and support all of our people in delivering it. Sustainability also means thinking differently, and in respect of our collaboration with SCAS, I think that will take an increasingly centre stage role going forward. We know that organisations, in general, the NHS has valued organisational sovereignty as prime. That clearly cannot carry on in the model that we would expect it, or we would have expected it to from days gone by. We are going to need to think about, in protecting our services for patients, what can we, what should we, what must we do together? We've made a really positive start on that, and I'm very glad that David has taken up the role of joint strategic lead. More of that to come in the year ahead. As Michael has said, and I would conclude by paying tribute to all colleagues around this table and multiple colleagues, and indeed Steve now sitting in the cheap seats to indicate his translated state. We are, as at the end of February, no longer in special measures. That is a mark of the fact that the organisation has made considerable progress on a range of different domains. And I'd also, at this moment, just like to acknowledge the enormous contribution that Steve has made over the last 2.5 years to help us get to that space. We genuinely couldn't have done it without you. And we are fortunate to have you here with us for a while yet to help us manage that post-transition. So thanks very much to Steve. Finally, to just reflect on comings and goings. So I too welcome Nick and also want to thank Stephen for all his work in getting us into a place where we've got a coherent and forward-looking digital strategy. We know that digital will be at the heart of one of the key 3 shifts, so it's something that we will need to return to. We also made a number of other appointments during the year. I think the job of the Chief Executive, I've often thought, is to set the strategy, to appoint the team and try and shift or help shape the culture. I feel pleased to be sitting around this table with a number of very strong colleagues. So to name those, Margaret taking up post as my deputy, Jen now joining us substantively as Chief Operating Officer, Simon as CFO, Nick I've already mentioned, Jackie as our new Chief Paramedic, and obviously Sarah as our Chief People Officer. So what I can feel confident of as I finish my remarks today is that CCAM should feel confident that it can face into what will be very challenging times with a strong group of executives to lead the organisation forward. Thank you.
Thanks, Simon. That's a very clear report. And I just make 2 comments for me. Really, really pleased to see the commitment to EDI. This is really, really important, and it's something that is very fundamental to me. I would like to see more women across CCAM in more senior positions. It's really good to look around this board and to see that that women are I think women outnumber the men here, which is Yeah, which is really, really excellent, and that must be the way forward. The other thing is, can I also echo what you said? For my sins, I've been around CCAM for a number of years, and I think this is no reflection on previous colleagues, but this is the strongest executive team I've seen in CCAM, and it does give me the confidence that we have the leadership to take this organisation further forward. But enough from me. Can I ask colleagues, are there any questions of clarification or challenge that anybody would like to ask of Simon? No? That's brilliant. So can we go on to the next item? And Howard, I'm glad I don't have to do this anymore, but you are kind enough to be chair of the audit committee, and your report and what you have to say to the board would be very welcome. So please.
Thank you, Chair. Okay, so the various categories: alert, assure, and advise. On the alert, there are two items there that are actually already on the agenda. So the risk management, we looked at the risk appetite framework, but that's a separate agenda item today, so I won't say much more on that. And likewise, on the digital resilience, we did note there are some gaps in assurance there, but we have a further update paper on the agenda as well. Also, by way of alert, we were updated regarding freedom of information compliance. There's a bit of a backlog in terms of the requests or dealing with the requests, although we were assured there is a plan in place to address that and get back to a sustainable position. So that's okay. On the assurance side of things, we received two further internal audit reports. And bearing in mind, obviously, the internal audit is the best type of assurance that you can get because it's fully independent. So there were two reports, one on accounting systems and one on procurement and contract management. And just by way of a reminder, as set out here, there are 4 levels of assurance, ranging from no assurance, limited assurance, moderate assurance, and substantial assurance. The 2 reviews that we received on those items received moderate assurance, which is comforting. And I think, therefore, for all of the internal audit reports for this year, we have received moderate assurance on all of those. So that's a really good, strong position to be in. But obviously, we mustn't be complacent about that, and we challenge the executive to drive further towards substantial assurance, so to get even better. But a good, solid, comforting assurance on those key areas of accounting systems and procurement and contract management. So that was good news. The external audit and the year-end process, I think the message is so far so good. So that's a really good improvement on some of the issues last year. So obviously still well into the process now. From KPMG, they're comfortable. Everything is proceeding well. On the advise area, on counter fraud, we're comfortable that there are effective counter fraud arrangements in place. Interestingly, we observed quite a substantial reduction in the reported incidents. And whilst that would be consistent with an improved culture, my curiosity was just to make sure that that's not a reporting issue, but it is nevertheless comforting to see quite a substantial reduction in reported incidents of fraud. So they're just checking that out, but again, quite positive news there. And then finally on the IQR, that's an ongoing process. I see for the IQR we've got some improvements, but I think still more to go. So that's an ongoing process. So we will continue to monitor that to ensure that changes are in line with our needs. So that's it. Thank you. Thank you, Chair.
Thanks, Howard. That's very clear and comprehensive, and I'm very grateful for you taking up the chair of the Audit Committee. Can I ask, are there any questions or any areas of further assurance people would be looking for? Mojcan, please.
Thank you, Chair. Thank you, Howard. With respect to FOI non-compliance, is the organisation receiving any financial penalties? And did the committee receive any timelines for ensuring compliance? Thank you.
The commitment on timelines is by the end of Q1 of 25-26 to get back into a sustainable position. In terms of fines, I'm not aware of any. I stand to be corrected on that, but we are in discussions with the ICO, Information Commissioner's Office, so they are aware of it. We're not the only ones in this problem, so I think there is an element of leniency for us to get back on plan. So I don't think there's any fine issues at the moment.
Thank you.
Thanks.
Howard, could I ask, maybe a question more for Simon as Director of Finance. Earlier in the year, I know you were focusing very much on improving the control environment, and this was an issue that had been raised in their annual report by Internal Audit last year. I just wondered your take on where we are. This is really good that we're getting moderate assurance now from most of our internal audit reports, but are you confident that all that you wanted to do to strengthen the control environment is in place?
So, as ever, there's always more to do. So we've made good progress in reasserting some of the fundamental controls in the organisation, so things like the standing financial instructions, an appropriate approach to procurement, contract management, etc., discipline around financial management. But as I'll come on to in the financial planning or the planning update, we are going to, as an organisation, need to become systematically good at productivity and efficiency over the next few years. This is not just a one and done effort. We are going to have to turn ourselves into an organisation that is productive by design, and we're not there yet, but we're making good progress.
Thank you. Very good for that assurance. And Howard, my final point, you're confident about the trajectory for the delivery of the financial statements and annual report, that we're on target?
Yes, I have spoken to KPMG recently, and they're fine with that, with the way things are going in terms of their audit and the year end. So, yeah, so far so good. I think we've still got a way to go, but so far so good. Yeah.
Okay, thank you very much. And I would echo I think we're going to be returning to the theme of productivity, and something that Simon said earlier, it's productivity but proportionate, needs to be balanced. We need to be more efficient, more productive, but we need to do that in a way that maintains patient care. And I think we all get that, and that will be our focus as we move forward over the next 12 months. We now move on to the next 4 items, which are really around how we have set our priorities for this financial year that we're in, and to do so in a way that makes us sufficiently agile to navigate us through the challenges over the next 12 to 18 months. So could I ask, I think it's Simon and Peter, these documents have gone through considerable scrutiny within our committee structure. So could I ask that you are brief in your introductions, and then we can have one final round of assurance before they are formally approved.
Thank you, Michael. So, in brief, we submitted a plan, first draft, on the 27th of February. That plan was compliant. In other words, it was a break-even plan and achieved 25 minutes C2 mean, so an improvement on our performance this year, so getting to patients who need us quicker. That plan was resubmitted largely unchanged on the 27th of March. That was the final submission nationally. Again, a compliant plan. Because of the differences at the national level between the expectations of the government, Department for Health, there is a final submission today, a final submission. Again, we will be submitting a compliant plan. Our financial plan includes £10.2 million of performance funding to help the organisation get to 25 minutes of C2 performance. This is split in two halves. The first half has been received, and that's because we submitted a satisfactory and tested plan. So it's satisfied what NHS England were looking for us to commit to do. The quality and the quality impact assessment is now complete and signed off. That includes all of our cost improvement and productivity plans. The plan that we've got is what I would call actionable and controllable. In other words, it is within our gift to deliver in the main. However, 2 minutes of the C2 performance improvement is linked to improvements in the system. So that's things like reducing handover delays in acute hospitals. NHS England acknowledged that that's not controllable by the Trust and will be holding ICBs and other providers to account for that improvement. However, it is not clear what happens to the other £5 million if we deliver everything we have committed to do, and the only bit missing is the 2-minute system issue. So what that means for us is we have to come up with a series of what I would call downside financial mitigations for that £5 million. That will be a number of things, but one of those things is writing to the system, to other Trust chief executives, to advise them that we need them to contribute to that 2 minutes, and to explain to them what would happen if they didn't. In other words, the system would lose £5 million. We would potentially have a risk to our financial plan. So we'll be working with ICBs and colleagues across the piece to fully mitigate that downside risk in due course.
Thank you. That's very clear. I'd like to open this up to question. It has been reviewed quite considerably by the non-executive and the executive. But Liz, as chair of the patient committee and quality, and Margaret can come in, are you happy? I know there's inevitable compromise because resources are constrained, but are we doing the maximum we can to minimise the negative impact on patients? I'd welcome your views on that, please.
Thanks very much, Michael. Yes, I think we're doing as much as we possibly can. I guess my concerns, which I think Simon's already mentioned, is around our reliance on the system to enable us to free up our resources, so hospital handovers, etc. We're also very aware of ICB change and turmoil over the next few months, and how we can manage our C2 mean with that level of turmoil and disruption going on. So I think as a trust, we're pretty confident in what we can deliver, but we're so reliant on system partners. And they're going through that huge change process that we went through a couple of years ago. So I guess for Simon, it's how do we manage that level of turmoil with our partners?
That's very helpful. Margaret, did you want to say anything as well from the executive?
Yes, and I think from an internal point of view, so Richard and I carried out the quality impact assessment and are quite confident that it's certainly focused on ensuring we continue patient care, patient safety and patient effectiveness and responsiveness. So in that way, we're assured. I think the only other thing to add is some productivity measures. We'll rely on really good partnership working with our trade unions. So we are focused on that and do recognise that that is something we need to maintain with the majority of our trade unions and all of our trade unions so that we can move that on.
Margaret, thank you for that point, and I really endorse the point that engagement with the staff side is really important. Can I just ask one other question, and it may be Richard or whoever. I think CCAM has a good track record of working with the acute in looking at how we help them manage handovers. I think it's not always has been as consistent as it might be, and I'm not, you know, are we confident? You said that we are going to go out and work with our partners to see how we can help in that way. Confident that's going to happen within a realistic timetable?
So the work's already underway. So the work that I described is the how do we mitigate the downside risk if it doesn't work.
Yeah.
The work to change things operationally has been happening, is underway, but it's different in different places. So I think it would be fair to say that in some ICBs the work is further progressed, which again is just something we need to keep an eye on.
Okay, thank you very much. Unless there are any other questions on this particular... Howard, please, yes.
Really just an observation and perhaps a question. One is that it's an excellent plan, but it's very ambitious in various different respects in productivity, and I applaud you for that, putting that together. But we need to recognise that it is a very ambitious plan. Some of the things that I picked out are the hear and treat target of 19.7%, and I'm a big advocate of targeting that sort of level, but that's a huge challenge from where we are at the moment, although we have demonstrated we have improved. I think we're about 15.5 at the moment, but that's a long way to go, so that's a very ambitious part of it. And I would like to be comforted that although I support that we do make sure that we do send out an ambulance when we need to. So what I'm saying is that whilst we're targeting this as hard as we can, and it's the right thing to do, I just want some comfort that that we're not using those targets to give people the impression that we're not going to do the fundamentals, which is send out an ambulance when it is actually needed. Yeah, that was my main point. Thanks.
Yeah, I mean, I think it's a really valid question. I think our strategy is really, really clear that our core purpose remains central to what we're doing, and we are really focused on making both productivity and quality improvements to our field operations response. In fact, we're at the moment piloting the local community dispatch model, which is all about optimising the way that we respond to those people who do need to be seen by an ambulance in their local area with our local pathways. So I think I can provide that assurance. There is a very robust framework around the way that we're progressing our virtual consultation and hear and treat work. And I think that is all about doing what is most appropriate for the patient. So perhaps some of the time that's taken in getting to the target, which we do need to focus more on the productivity around hear and treat and virtual response, is really about us getting it right so that those hear and treat responses are successful, and we monitor the kind of balancing outcomes that will give us the assurance you're talking about, Howard. For example, we are focusing also on like failed hear and treat repeat calls to make sure that we're not inadvertently directing people to the wrong outcome, and there is no evidence that that is the case at the moment.
Thanks, Jen. That's very clear. Karen, you wanted to...
Thank you. Yes, just going back to the handover point, which of course is just a particular point in a patient's journey. And it's good to see the work that's going on in other papers today around the patient pathways, which are clearly critical to that in our models of care. But I'm also aware of the provider collaborative work that's going on. And my sense is perhaps that different areas are at different degrees of maturity in that. And I just wondered if you could say a little bit more about your confidence of that, because obviously the impact of the wider piece of work about what some of these patients may not even need to go there in the first place, what your sense is of where the risks might be.
So if I maybe start and then hand over to Jen to give some detail. The first thing I should say, and it's obviously as it's a public board, is to acknowledge and thank the contribution of our acute colleagues in helping make us one of the strongest ambulance services for handovers, I think, in the country, if not the strongest. We were long before the 45-minute standard, which is now a thing, became a thing, colleagues in this organisation were making that a reality, and it has contributed year on year to our performance. ACE and the National Ambulance Association have published data that strongly correlates performance with handover delays, and so we know that there is empirical data backing up the fact that point you just made, Karen, that getting that right is really important for patients. I'd also say that concerted effort on this is something that does lead to improvements. So, for example, East Kent was, as a hospital, very challenged in this regard, but with the focused effort of commissioners, the provider, ourselves, and other community colleagues, they have turned that performance around, and that has been really welcome to see. That said, we still have places in our patch that are challenged and were they to be fixed, so I'm sure Jen will comment on that in a second. I'll just end my comments by saying that we're moving in the new performance standards that we will be expected to adhere to a fully compliant 45-minute handover time as the minimum standard, as opposed to being advisory. So that is welcome. And the other thing I'd just draw to the board's attention, in the context of the changes that are being made, the National Ambulance team will be leading the performance management conversations going forward. Previously, we would have had those conversations with our ICB, but recognising the regional role that ambulance providers have, I welcome the fact that the National Ambulance team will be making sure that those handover focuses across the entire patch will be maintained going forward. But maybe invite Jen to comment just on some of the areas where we may still have further work to do.
Thanks, Simon, and thanks for the question, Karen. So in terms of provider system collaboration, I think that is actually the critical piece that we need to work on now, having kind of got the in-principle agreement within our plan that we'll have a kind of system productivity approach with the ICB and the commissioners. Actually, to make that a reality, what that requires is ongoing collaboration with our particularly acute but also community provider partners. Whether formal provider collaboratives in the kind of NHS structural sense will be the vehicle for doing that, I think remains to be seen. And I was discussing with my regional chief operating officer counterpart yesterday, Dan Bradbury, about where there might be space for us to support the development of provider collaboration in the sort of community space, because at the end of the day we are, in a sense, a community provider, and that's where we can operate at that kind of scale and help perhaps to address some of the challenges of the community pathways, which are critical actually to solving the handover issue. You've got to start further upstream, haven't you? That is not easy. It's not simply a case of one provider taking over another provider's operation. There are much more fundamental challenges to overcome, but certainly strategically moving forward, I'd like to see us taking a provider coordination role there. In terms of hospital handovers, we do, it is a little bit batter rat. The challenges do move around the system and reflect to some extent the challenges that acute providers are experiencing with their whole system flow. So I would say the kind of key challenge at the moment is in Sussex with University Hospital Sussex, and that's really important that we work with them, with Richard and others who are leading that interface with them on their quality plan, because this is about high quality care for patients. It is not about taking someone to the A&E and leaving them after 15 minutes, come what may. And I'm really assured when I spend time with teams that they are, when implementing immediate handover, they're doing that in a way that first and foremost says, is this safe for the patient? And then secondly, how do we balance the risks of the different parts of the pathway here? So I think we have a really good framework in place. Simon's referenced that being embedded over some years. We can optimise that, but we are going to put some specific focus, and this is not a new thing, on to Sussex, because that is an area of challenge at the moment.
Thank you. That was a very good description. I'm so happy with that. Thank you. Can I ask one final question? We're spending a bit more time on this, but I'm deliberately doing so because it's really important. we've spent a lot of time over the last 2 years engaging with our people. So the strategy was developed not in a top-down way, but with our people. If you went out and spoke to, I don't know, a paramedic in East Kent or wherever, or an operational manager, would they buy into this plan? Do you think that, you know, that they're happy with it, they're committed to it? It's a difficult question, and I know there's always an element of balance, but Margaret or whoever would like to answer that question, or Jackie, I don't mind. Yeah, please.
Thanks. Yeah, I'm very happy to answer that question. I think the answer is a resounding yes, and I've heard that from staff that I've been speaking to out there. And one of the interesting things that I've heard from colleagues actually reflecting is the caseload that they see on double-crewed ambulances is quite different, where we've got good levels of hearing-tree in particular areas, so they're very, very, very supportive of this change.
Okay, thank you. I just wanted that assurance going forward. Can I conclude this session? So I just want to summarise, because this is really important. What I'm hearing is universal support by this board for this operation plan. Really brilliant. I want to go on record as saying that the government and the Secretary of State have challenged the NHS to be ambitious, to look for ways in which we can improve productivity and maintain patient care. So I think genuinely CCAM has risen to the challenge on this, in terms of that we have a good plan that will help us navigate the future. It's not without risk, as people have said. We are very much dependent on our system partners, but we don't do that in isolation. We don't sit back and just let them get on with it. We are working very closely with them, and will continue to do so through the collaboratives and through the ICBs. So I am confident about this plan. We do need to monitor it very carefully, and the risks associated with it are included in our BAF, so we will return to this. But for members of the public and media, I think this is a good plan and will help CCAM continue to deliver what it is here to deliver. Could I now go on, though, to the remaining 3 items, which hopefully give us further assurance, which is board assurance framework, Peter?
Thank you, Chair. This version of the BAF supports year 2 of our strategy. As you mentioned, Chair, this is we had much engagement over the last few months. In fact, we started this probably in quarter 3. So we're in a much better position than we have been in previous years. It's informed by the work of the operating plan that Simon's just talked to, and we reviewed it at the joint board and COG meeting just last week. Many, as you'll see from the BAF, many of the priorities are sort of evolution of year 1 of the strategy, so you'll see hopefully some continuity. Also, you'll see the structure has remained unchanged, so it's probably the third year now we've got this structure. It's well established. I think it works well. In the pack, slide 9, it summarises the key areas of focus, which are then set out in further detail in the remaining slides under the headings of the 3 strategic aims. The board assurance framework, important that we get sign-off of this by the board today, because it will help then to drive this board meeting and the meetings of the board committees over the next year. Those related work plans are currently being finalised and will come to the board meeting in June, which is just in 4 weeks' time, at which time we'll also start then to report progress against delivery of the items within the BAF, including, as you've just mentioned, Chair, how we're mitigating the related risks. And as we picked up at the Audit Committee last month, there's work ongoing with the IQR, and hopefully the aim is by the June board, this version of the BAF will help to draw more closely the link between the outcomes in the BAF section to the integrated quality report. 2 more things. So one of the key strategic priorities in the BAF is models of care, has been referenced already. The board story today will cover that. In the board pack, in the board assurance framework, there are some slides that cover a summary of the progress of the Tier 1 and Tier 2 programmes from the year just ended for the board's information stroke assurance. And as I say, the continuity will be that most of those are then sort of evolved into the BAF that we have for the coming year. So subject to any questions, Chair, I'm asking the board to approve the BAF, which will then guide the focus over the next 12 months.
Okay, again, a really important document that, sorry, again, a really important framework that helps shape the work that we do and give assurance. This has gone through a considerable degree of scrutiny, but because this is a board in public, I'd just like to ask each chair of the assurance committees whether you're happy with this and this will enable you to hold to account appropriately. So could I start with Paul, your chair of finance and investment?
Yeah, we are happy with this. It's an amazing piece of work, backed up by some amazing plans and great teamwork within the executive team. The only level of alert we had at the Financial Investment Committee was around how do we measure progress? How do we have to change the board to support this? Because you're not going to flick a switch and everything's going to happen from the start of the year. It's going to drip in through the year. And how do we actually measure that we're on track or not? Because I think we have to be more patient and supportive, and it's how can we help?
Yeah, it's a really good question, Paul. I have reflected with the executive team on the fact that all plans in the NHS are ratcheted with a higher level of risk probably than last year. And so what we propose is to have formal quarterly stock takes of the entire plan and then report back through board committees and to this board as to progress, whereas our previous mode of operation would have been to update incrementally up to the board. We feel that the discipline of holding those formal quarterly stock takes, the first of which will be in July, will enable us to report progress in a much more systematic and disciplined way, which I believe is the only way we will have of balancing the internal and external risks that we're carrying. So that's the kind of thematic change that we're making this year to address that challenge.
Thank you. Jen, did you?
I just wanted to say, I think that's a really important point, and just building on what Simon said and what Pete said about the IQR as well, I think that there's real value in us looking in a regular and integrated way at our BAF IQR and kind of progress in through the quarterly reviews that Simon's mentioned, you know, in effect using EMB or the quarterly reviews as a committee of the board, and aligning that with the IQR. So I think we can make a really helpful evolution of the way that Pete's mentioned we focus the regular reporting that we have oversight of on the board and BAF measures that we're aiming to deliver, with supporting information about how we're delivering that and what the broader picture looks like, so that monitoring how we're doing against the plan in quantitative as well as qualitative terms becomes part of the kind of integrated framework. So I'm really hopeful that that will take us yet another step on our journey there.
Okay, thank you, and I 100% support for that. That's really good. Liz, can I ask you from patient quality?
I think from a patient quality perspective and the committee, we're fully supportive of the BAF. I think it helps frame our agendas, what we're focusing on and the level of assurance we require. I think we need to be clear this is transforming healthcare. And I think we need to really understand the impact of our patients who expect to dial 999 and get an ambulance.
Yeah.
So I think we have that level of confidence and assurance, but we also have to assure our patients that the care they are receiving, whether that's virtual, whether it's hear and treat, whether it is an ambulance being provided, meets their needs and ensures we get the right quality outcomes. And I think the model of care working will absolutely support that and free up the resource to deliver to those patients. But it is a period of transformation.
I really like your points. Can I ask, because I know you've led and done a lot of work on patient engagement, so we'll be getting that feedback from patients, do you think? Or do we need to do more?
And I'll probably ask Margaret to come in as well. I think there are concerns still from our patients, and certainly we engage with Health Watch, etc. There are still that level of understanding that we are that emergency service that will always respond no matter what. And there is trust in us to be able to do that. So changing that, but also our patients and the feedback is they want that speed of response. So they want to talk to a clinician, they want help as soon as they can get it. But I think it's just managing that transformation. But I'll ask Margaret to come in.
Yeah, thank you. So first of all, we've really increased the number of network points we've got now to be able to address and speak to different groups of patients. But we also have a large staff group who we need to ensure understand our strategy and our group A and our group B, as Richard can really eloquently talk to and we'll be looking at later, because the more often as we go into people's homes, we can just in a way describe what that model is whenever an opportunity comes to say in future this is the kind of thing we'd want to offer you. I think the more will have an impact across our population. This is a societal problem, isn't it? Because people can logically, rationally, in the cold of day say, no, we understand, the ambulances absolutely need to go to that person who's having that cardiac arrest. But actually, if it's me on that day in agony from a tummy ache, an abdominal pain, I want that ambulance to come to me. And that's what is always the paradigm when we're dealing with health and how we set out our operating models. So there's work to do, I think, internally, and Richard has certainly focused our attention on that we need to go back out now and refresh the discussion about the strategies with David and his team all round, so that they can be our voices as much as our formal network. The last point I'd make, Michael, is that we do have still pockets of the population we don't reach. We don't represent them in our staff groups. We don't have ways into it. And I know in the past, Michael, you've certainly challenged us when we've talked about, the hard to reach, because they don't believe they are hard to reach. We're just not getting there. So with the work we're going to be doing with Health Inequalities, and Julie's here, focusing our attention on what are our priorities, and by the end of Q3 we'll have those kind of priorities through. That's something we really do need to think about. What are we going to do differently to enable us to engage, not only attract into the organisation so that we are starting to tackle our EDI narrative, but also engage to understand whether we are actually meeting the needs and getting their feedback on what we're doing.
Thank you. I'm really pleased about the EDI context there, so that's great. Max, people, please.
Yeah, very supportive of BAF as a framework for People Committee. And thank you, Paul, Jen and Simon, for your builds on how we'll track progress. I think for me that was potentially where we have more work to do. And really looking forward to working with the BAF to shape the cycle of business and agenda for People Committee going forward. So very supportive.
Thanks, Max. And I should have thanked you. You are the new chair of the People Committee, so thank you. Cameron, as Sid, I'm really interested in that you're assured by this process.
Thank you, Michael. Yes, as you say, we've had numerous discussions on this. So I think we've had lots of opportunities to refine it over a period of time, and I've very much welcomed that. So I am assured by that. I think what I encourage us to think about is in doing things in different ways, and many people have made this point, we're also thinking about, well, how do we know it's working? So I'd also encourage us to keep being reflective about this how do you know question and evaluation. And, there's lots of pockets of expertise out there of measuring things differently. Are we sure we're measuring everything that matters to the patient? And are there opportunities for us to think about developing more patient-related outcome measures where we find out from some of these groups about what is important for them, because in my experience it's not always what we think it is. So I think that's ongoing work, but it's just, I think, a critical thing for each of the subcommittees to continuously reflect on. Thank you.
Okay. My final point is to David. I always remember since you've been here, you challenged us to be more data-led. You confident, from your data perspective, we're getting the information, or we'll get the information to track what's happening?
Thanks. I wouldn't advocate for taking that. I think it's a very it's something we talk about on a weekly basis as an exec team. How we measure things that are relevant, and Jen has talked to the process we're going through with the IQR. The one thing that I'd say, just to connect this to the discussion we're about to have about models of care, which is really at the core of our strategy, isn't it? And I know Richard and team are going to introduce that through, is a lot of times, I don't think at the moment we're measuring everything that is relevant to all of the different presentations that we see as patients. And I think what we're going to hear from the team in a second about models of care, I think will challenge that notion of, are we measuring all the things that are relevant? I think we're measuring the things we have to measure at the moment. And we're certainly measuring some things that are very important to a proportion of the patients that we go to. But what does good look like for somebody who's presenting, at end of life? We're going to hear from that in a second with mental health, falls and frailty, because success may mean different things for different people, and it's not always going to be measured through, a C2 time response that is quick or a cardiac arrest survivability. Those will be very important for some patients, but not for all. So I think let's hold a pin on that question, and then let's let the discussion around the models of care lead us through then what does that mean as we think about how we mature our thinking going forward. And I think it's going to be a process that we need to go through in the coming years.
Okay, that's a really good segue into the next item. But and so thank you for that, and thank you to all colleagues. I take it from what I hear is that we approve the framework going forward. Really take the point that Jen and Simon have said that we need to review this quarterly, or the executive do, and we need to look at it. And I also like the point that you've said, Karen, about reflection and asking, are we asking the right question? So, but I'm really assured by what I've heard from the executive today. So thank you for all the work that's been done in support of this. Peter, could we go very quickly on, and then we'll to risk appetite and board development?
Two more things for me before we move on into the board story. So first thing on the risk appetite framework today is that I'm personally really confident that this will help us take a step change in our approach to risk management. Key benefits for me will be, in terms of this approach, will be ensuring better clarity and focus on risks, those outside of appetite. This in turn will inform the amount and type of risk the board is willing to accept in achieving its strategic aims, as we've just talked about in the BAF. We've engaged with others in the development of this framework, so we haven't reinvented the wheel. We've engaged particularly with our colleagues in the North East who introduced this, I think, about 12 months ago. We've used their learning in particular to ensure that we phase this as the proposal sets out. So we'll start to roll it out with the board committees, EMB and the senior leadership team. I've reflected to both the audit committee and EMB that I'm certain that we haven't got this right from today, and therefore as we implement it we'll learn how to adjust it, and we'll make amendments which supports again the need to sort of pilot this and phase it over the next 9 to 12 months. But that said, we need to start using it in earnest. So we'll start in the next round of committee meetings to undertake detailed review of the BAF risk that we've just talked about, relevant to each committee, and look at through the lens of the risk appetite. So what falls within, what falls outside of the risk appetite. Spoiler alert, done some analysis already, and the majority of our BAF risks fall outside of the appetite that we've set out in this framework. So to illustrate how this framework will be used in practice, so the questions from the insurance questions from the committees will then be, have we got the scores right, have we set the appetite right? Assuming those things are fine, then the board will explore and assure that the management are taking all the relevant actions to mitigate the risk as quickly as they can. Therefore, coming up with its view, the board's view about whether it's willing to accept a risk outside of appetite and for how long. So you can see, almost immediately how the conversation around risk changes by use of this framework. So I'll stop there and just ask that the board formally agrees it. And as I say, it'll be phased over the next sort of 9 to 12 months, and we'll start to use it through the next round of board committee meetings.
Unless anything to the opposite, I'm assuming it's approved. This has gone through considerable scrutiny. The only question I'd ask is that you keep the board up to date through Howard's committee that we're getting this right. And I would stress the point that many have said what we are doing is transformational within the organisation. That's not without risk, but we need to be confident that we take those risks where they're well managed. But thank you for all that's been done. Can we go now on to the board development plan?
I can do. So first thing, another thanks to Steve Lennox for his support particularly in the sort of thought and thinking that's gone behind this plan. Purpose of the programme is to help the board become as effective as it can be, and in doing so support its role and oversight of the BAF that we've just talked about in terms of the strategic priorities. Few things just to put out. So we'll utilise some external support, as we will do tomorrow in our first session. But we'll largely be drawing on the expertise around the table, both from an exec and non-exec perspective. Two main drivers that's informed the plan: the well-led review that you'll remember for those that are around from the governance coach in early 2024, and the recent publication on the Insightful board. In this proposal, we're asking, in addition to the board agreeing the plan, for it to adopt the 6 responsibilities set out in the Insightful board. And the plan also picks up from the governance coach review, the sort of 3 themes from that: governance, connectivity, and our ambition. The board will know that elements of this plan we discussed at the last session just last month, and that feeds into the next one tomorrow, particularly in the space of ambition through the we statements that are being developed. So ask Chair is for the board to formally agree the plan, and to adopt the 6 responsibilities. And what we'll do as the board's purpose, and what we'll do is we'll update the board terms of reference for June to reflect that.
Okay. Are people happy to approve this? Thank you. Thank you again for all the work that's been done. Again, we are a learning organisation, we are a learning board, and we will continue to adapt and improve. But this is a really positive way forward, so thank you. Can I now move on to the board story? Richard, you're going to introduce this. I really want to hear more about all the excellent work that's been done on models of care. So over to you.
Great, thanks very much, Chair. It's a great pleasure to invite our clinical leaders to the board this morning. Those that are presenting, if you want to make your way to the chairs where the pointer is so you can change your slides, then you're welcome to do so. I'll just say a few words by way of introduction. We've got a few slides to show on the screen, so those that have got their back to the screen may want to just turn around to be able to see them. Oh, you've got a screen. Okay, lovely. So we don't expect you to read the detail of these slides, but just to give you a highlight and flavour of where we've got to, we published our Trust Board strategy last March for models of care. Simon mentioned this in the Chief Exec's report earlier on, so I won't go over it in detail around the broad categorisation of our patients into Group A patients that require an urgent ambulance response, for specialists pre-hospital care in an emergency situation, and our Group B patients who call 999 but don't necessarily need a resource to convey them to hospital but do need healthcare in other settings, who we manage in a different way, hopefully through virtual means. And the way that we want to deliver our strategy over the next 3 years is a challenge for us, and the way that we've done this is to break it down into 11 health conditions or patient groups that allows us to look in detail at what it means for those patients with those health conditions, how we would treat them differently if they're a Group A patient or a Group B patient. And we've seen this slide multiple times at board, so I won't go into the detail of it, but I think it's always helpful to refresh our memory of what our trust strategy is and the way it's very different to how we operate now. This slide, again, is very detailed, but I've used this slide to illustrate the fact that if you look at the 11 conditions we've broken it down into, each one of them is led by one or more clinical leaders from the organisation. This is very much a clinically driven strategy and a clinically driven implementation plan. And we're going to be hearing shortly from some of these clinical leaders of these groups around what it means for them over the next 3 years in terms of delivering for our patients within that group. And some people may challenge us and say, are you doing something different in CCAM to what the rest of England is? And Jen quite helpfully reminded me a couple of weeks ago that the Association of Ambulance Chief Executives have come up with a blueprint of what the ambulance service looks like for the future, and they put it into this illustrated slide here. And actually what they've come up with is exactly what we're doing in CCAM, and I would like to say that I think that we got there first. It's reassuring to know that we're not going off a tangent here. We're doing something that others feel is evidence-based and is best for our patients. So now I'm going to stop talking because we really want to hear from our clinical leaders. And the three areas or the three models of care that we've chosen to bring to board today are our three focus areas for the coming year. And that's end-of-life care, and we're going to hear from Jen, falls, frailty and older people, and we're going to hear from Tom and Julie, and reversible cardiac arrest, where we're going to hear from Dan. And Andy Collin, our consultant paramedic, is our subject matter expert, clinical lead for the programme, and Andy's going to say something by way of introduction, I understand, as well. So do bring your chair forward as well if you want. Yeah. Go. You've got your own pointer, so you can control your own slides.
Thank you very much. So I think we just need to probably remind ourselves of the slide just further back, really. So this is where I think in the conversation before we started this, we were touching on the points that David was making. In order to be a world-class, in order to be a world-class ambulance service in terms of cardiac arrest survival. So if we think about reversible cardiac arrest as being the apex incident for an ambulance trust, when people ask me what do I do for a living and I say paramedic, they say, so you go to car crashes and save lives. But we know our workforce does a lot more than that. But a lot more than that often comes at the cost of having resources available to respond to reversible cardiac arrest and all the other life-threatening conditions that we would be associated with. And so to echo Richard's point, how we've divided the workforce up and how we've applied the principles of virtual care, subtly but importantly, this is not about driving up here and treat. In some ways, it's actually around driving down, see and treat. So that speculative send of ambulances, where half the time they actually leave scene without a patient in the back. And that talks to providing the right care for the right patients in the right place and at the right time. Changing how we respond overnight is all part of these models of care. We have a single model that operates the same at 10 o'clock in the morning as 10 o'clock at night, or 2 o'clock in the afternoon, 2 o'clock in the morning. So aligning our models of care to the health economies and the specialist services that are out there that we currently don't leverage is all part of this. And I hope you hear all of this really echo and resonate through the descriptions of the models of care in detail from the experts. Thank you.
Thanks, Andy.
I'll vacate the seat.
On to me. Morning, everyone. My name's Tom, so I'm one of the practice development leads, and I've been supporting Julie with the development of the falls, frailty and older people model of care. Don't like how I was introduced as an expert by Andy, but we'll roll with it. So where are we currently with this cohort of patients? So we know that a very large proportion of the patients that seek support from the Trust are either frail or are experiencing a fall-related issue. But a great number of these either have no injuries or minor illness, minor injury needs. Historically, we've always been very reactive to this cohort of patients. So, and we know that a vast majority of them are categorised as a category 3, category 4, and will sit in our stack waiting for help for many, many hours. And it also leads to multiple handovers of care before we actually resolve their need. This reactive approach leads to a lot of avoidable conveyances and hospital admissions. And that's despite a lot of these patients actually already being very well known to our partners within the healthcare system. There's a really clear opportunity to shift this reactive model to more of a proactive and system-wide intervention, leveraging things like virtual triage, frailty scoring, and optimising the use of alternative care pathways. And also huge opportunities to expand the use of community falls teams, so including our volunteers, CFRs, colleagues from Fire and Rescue Service, and scaling that up, particularly to reduce the risks associated with long lie and people on the floor. Very much the national direction of travel for this cohort of patients is shifting towards a truly patient-centred but also integrated model of care that looks at prevention rather than just being, responding to the need and reactive. And all of the sort of relevant policies, very much the language around them talk about community-based and non-conveyance alternatives for older people. Some of the highlights, so being proactive in both identifying and managing people who are frail and people who fall through early triage and also frailty scoring. Very much it's around, this is not an ambulance service problem, this is our problem collectively and collaboratively alongside our partners within the integrated care system, particularly colleagues from urgent community response, primary care networks, same-day emergency care, and also the voluntary sector. So what will the new model look like? So we will provide early rapid triage and virtual consultation by the right clinicians to support that very early decision making with regards to their care. It's really important that we still ensure a very timely face-to-face response to patients who have fallen and are on the floor, but not necessarily with a big yellow truck with wheels on it. Again, it's about responding as a system to these patients that are on the floor. We want to optimise the use of our system partners, so by streaming to the most appropriate service for that patient, including things like UCR, falls teams or rapid response services. As I mentioned earlier, these patients predominantly are already known to the healthcare system. They're not new patients presenting with new needs, and we need to stop treating their interaction with us as a brand new need. So access to shared patient records is really key to ensure that we continue providing care that's in line with all of the other services that know them really, really well. And part of that proactive identification and risk assessment will be frailty scoring, using things like Rockwood Frailty Score to identify those patients. So what does the next year look like? So thanks to our QI team in the Trust, one of the quotes that I give often is that without data, you are just a person with an opinion. And I think that's really important here because anecdotally, we know that we respond to a lot of older, frail people. We respond to a lot of people who fall. But do we actually know what that cohort of patients look like and what we're actually doing with them? I should have mentioned at the beginning that you can be frail but not old, and you can be old and not frail. And both of those cohorts of people can fall and not fall. So grouping them all together maybe isn't the right way. We need to really get into the detail of who are these patients and what are we doing with them currently in the system. So that's kind of the foundation for where we kick off over the next year. We want to scope the potential for a dedicated frailty clinical lead to support the implementation, but also that system-wide collaboration. We need to review what current training we're providing with care, not only face-to-face care, but also that virtual remote care. There's a lot of services out there for frailty and falls, but do we know what they look like and are we using them well? So we need to kind of map all that out. Identify the governance processes to embed the changes. Most importantly, in the here and now, is reduce those long lies. Huge adverse outcomes from patients just simply being on the floor for a long period of time. So we need to do some work over the next year to get that response and get them off the floor early. A key to that is going to be the early recognition and rapid triage and utilisation of community responders. We're already doing a huge amount of work around that virtual triage, but we can build upon that and look at the clinical oversight for these lower or perceived lower acuity patients. Strengthen access to community falls teams, so that includes our CFRs, fire and rescue service, but also lots of other partner organisations, and kick off that true system-wide integration and conversations around intervention and prevention. And I think Jen's next.
Hello everyone, my name is Jen. I'm a palliative care paramedic and end-of-life care lead for the Trust. So looking at the scale of the problem, so what happens now in palliative and end-of-life care? So we have a significant number of patients that we see that are currently non-commissioned workload for CCAM, and that changes significantly from where we are across the Trust, and it'll be interesting to map that against deprivation and population as well, because I think there's a lot of inequalities in those numbers that we're seeing as an ambulance response. And we know that end-of-life care patients present a challenge to our staff. They struggle with confidence, they struggle with pathways, and by the time a patient or a family ring 999 for a problem, they've often tried all of the community pathways already, and we're kind of last resort, which leads to the long on-scene times. And I was quite surprised. I thought an hour and 39 for me was actually quite low, because we do see some really significant outliers in that of 3, 4, sometimes even 5 hours. So it does present a significant burden to the Trust. We know from research by Marie Curie that over half of people who are in their last 3 months of life use the ambulance service. And that's not just us, that's across the country. And we know that that number is going to increase with an ageing population. So to put that into context from a system perspective, research from the Nuffield Trust showed that £22 billion it was spent in 2022 for patients in their last year of life, and half of which was on healthcare. So every £5 spent on healthcare for people in their last year of life, £4.80 of that is spent on hospital care, and £2.80 of that is spent on emergency hospital care. So the emergency sector for patients who are dying is huge, and that's driving this national change for end-of-life care and shifting care into the community as well as other sectors as well. So what's on the horizon? So we know that the number of people who are dying is going to increase, and by 2035 we're going to have an additional 79,000 people dying across the year in the UK. So to put those numbers into context, in 2022 we had I'm not very good with numbers, you have to bear with me. We have 577,160 deaths in 2022. So that's going to be in a total, or a predicted total, of 656,160 by 2035. So to put that into perspective, in 2022, we had 607,922 deaths. And in 2021, we had 500,086, 334 deaths. So we're going to have more people dying in 2035 than we did during COVID. And I found that a really sobering fact. So that's the importance of getting our models of care right now, finding our place in the system and trying to work out what is our non-commissioned workload now, how do we optimise what we do as an ambulance service now, and how do we work within the system, what's our place, where do we go, what do we do. So we absolutely need to work with our system partners. We're part of the solution, but we are not the entire solution to this problem. And we need to work with the system to plan more appropriately, and our part in that links heavily with Tom's model of care of using things like Rockwood scoring. How do we recognise that deterioration? We might be the only trust that's potentially seen someone who's fallen 3 times in the last month, and that's unusual for them. So how do we recognise that last year of life, and how do we escalate that back to the system more appropriately, so we can then plan, put things in place that then reduce an end-of-life care crisis and therefore reduce the need for the ambulance service and mainly have better outcomes for patients. We need to optimise the delivery of our care within our current commissioned envelope. So there is absolutely a place for us in terms of palliative care emergencies. So things like spinal cord compressions or terminal bleeds. How do we make sure our staff are clinically confident and we have the pathways in place to be able to deal with those quickly? I've talked about how we need to develop confidence in identifying the last year of life, and we need to develop the pathways through this model of care to refer people back into the system for that review. And then there is this gap with the current state of the hospice sector being in complete turmoil, community care being in turmoil. arguably we're in a bit of turmoil. So what is this gap in the system and how can it be filled? I don't think it should be filled by us, but I think there will be a part of us in that solution, and how we work with charity partners and how we work nationally to work out what that means for patients. They get the care they need at that point of crisis. So year one deliverables, looks like I've got a lot because they're quite small writing, so apologies. So similarly, we'll be baselining data, mapping what our activity looks like, getting the coding right. Where does that map in terms of inequalities and services that are already out there in the community to meet those? We need to plan our workforce development. Do we look at opportunities for specialist palliative care paramedics in the ambulance service, rotational posts? How do we work across the community? What does our workforce look like? I don't have the answers to that at the minute. We need to look at what our end-of-life care leadership roles look like and how we map that to the current CCAM structure and changes. We need to set up our internal and external reference groups and expand what we already have to keep not only our people but the rest of the system involved and engaged in this progress as we try and work at pace. We're going to lay the groundwork for reducing our on-scene times for end-of-life care calls, and that will come with clinical confidence and increased pathways and increased understanding from the rest of the system. And we also need to start looking at how we manage DNA CPRs and call handling, which is arguably our biggest issue in end-of-life care at the moment, which will allow us to respond more appropriately to cardiac arrest calls, which segues me quite nicely onto Dan.
It's like that's planned. Morning, everyone. Thank you. I'm Dan Cody, consultant paramedic for Critical Care Resuscitation and the interim deputy chief medical officer, and here to talk about reversible cardiac arrest. So we, as CCAM, attend approximately 9,000-ish cardiac arrests a year, of which about a third of those, so about 3,000, are suitable for resuscitation, and that's the cohort of patients we're going to talk about. Now, reversible cardiac arrest hopefully doesn't need much of an introduction and doesn't really need me to tell the story, because we've got people that do that for us. So on the slide you've got Gemma, Graham and Chris, just 3 of the 307 survivors last year, and it's them that tell the story for me. Last year we saw the highest ever recorded survival rates of cardiac arrest in the UK as a leading ambulance service in that space. 11.5% survival for all comers, which is 2% increase on the preceding year, and more than 2% higher than the national average. So we're going in the right direction, but there's more to do. But what we do have is a lot of data and a really good team that analyse that for us and help us understand this cohort. So the purpose of this model of care is to increase the number of survivors from reversible cardiac arrest. So the things that we know. So there's some really basic things that won't surprise us. That those that survive, on average, were responded to quicker. And there's an inextricable link between how quickly we get to someone and whether on their chance of survival. Likewise, and a link to the first one, is those that receive their shock quicker were more likely to survive, and it's inextricably linked. The time to first shock to survival, which drops off quite dramatically as time goes by. And it's why the 7-minute exists, but we should always be obviously looking to get there sooner than that and taking all the opportunities we can to optimise that. So I suppose that's a big part of understanding how we develop this model of care. And then going further, for those that were given a defibrillator shock from a public access defibrillator before our arrival and achieved return of circulation before our arrival, had a 93% chance of survival. Now, albeit that's small numbers, that's pretty standout, it's pretty staggering, and it tells us the things that we need to know. The quicker we get there, the better people do. The quicker they get shocked, the better people do. If that can all happen before you even arrive, great. And that's where our focus needs to be. And we hear about health inequalities much more frequently these days,
and it's present in resuscitation, and we're starting to understand that. So it won't surprise you that the incidents of cardiac arrest are in our areas predominantly of greater deprivation, greater health need, greater comorbidity. But where are our CFRs and where are our public access defibrillators? They're in the more affluent areas. They're in the areas where people will give their time over or fundraise for a public access defibrillator. So they're not in the right places. So we need to obviously address that as part of this ongoing work stream. So very simply, we're going to go back to basics with this model of care and focus it around the chain of survival. The chain of survival has been around for a long time. It's internationally set, slightly different wording in each country, but ultimately says the same thing. That the four links in this chain, if each one is in place and at the earliest opportunity, the better people do. So that we recognise that someone is in cardiac arrest and we call for help early. And that's not just what we do on the phone, that starts before that. That's a member of the public having the confidence to recognise cardiac arrest because maybe they've been part of an outreach, maybe they've been part of community education, maybe they've had it through school or through the workplace, and they understand. So they call for help early. When they do call for help, that we answer the phone in a timely manner, that we are able to identify cardiac arrest and give pre-arrival instructions and start that early CPR, the next link in the chain of survival. But also, how much easier is that if the person on the end of the phone already knows CPR because they've been part of the community programme, they've been taught it in school, they've learnt it at work. And that we signpost them into a public access defibrillator where one is available, which again, how good would that if businesses invested, schools invested, etc., and that we have them where we need them, where we know the incidents of cardiac arrest are. And our response is quicker, so when they're not available, that they're getting those things still sooner than they are now. And then lastly, if all of those things go well, which we know they do when all of those things are provided in a timely fashion, then the next part is looking after them once their heart's beating again, because they're not out of the woods yet. Some of them do sit up and start breathing in TV style, most don't. And they need ongoing care of their brain and organs for them to go through and survive with a good outcome. Because it's not just about survival, it's about surviving to hopefully return to your previous state. So with that, that's simply what we're going to focus the model of care on. And throughout the whole thing, not just year one, but all we're looking to do is increase the utility of our CFRs and public access defibrillators to leverage that time to hands on chest and public access defibrillation, that we improve the already good work that's going on in EOC around just improving confidence to identify cardiac arrest. There might be also the use of technology such as AI, for example, to leverage that for us and get that hand to chest time in a positive position. That through all of the other work, and that's where all these model of care are really linked, that by doing the things that have been described by colleagues and throughout the other models of care, it releases the vehicles to be able to give that timely response to our C1 and C2, our Group A patients. That we get then, therefore, the mean time to first shock down, which currently sits at 12 minutes for us if we're delivering it. And we'd like to get that under 10, and obviously with an increased use of public access defibrillation. Increase the crowdsourcing opportunities through apps like GoodSam, and there's a piece of work going on this year around encouraging sign up to that and increasing the use of that. Increasing workforce confidence. Our crews are really good at this, but at the moment in the current setup, as was described by Andy, at the moment in our current model, the average paramedic in CCAM sees their cardiac arrest twice a year. In these, as we change our model, that will grow and their exposure to the Group A patients will grow. And with that, we then need to support them, give them the tools to ensure they're good at it. And we want to be ambitious, and ideally we want to be really driving survival to discharge, but we don't want to overpromise early on, and we're looking at 12%, so going from 11.5% to 12% in the next 12 months whilst we start to make those gains. And then through, again, the models of care, looking at the skill mix that we put in front of a cardiac arrest patient to make sure they've got the right care to deliver each element of those links in the chain of survival. So that'd be through CFR through to a CCP or a HEMS team to be able to provide that full suite of care. And that is it from me and us as a panel. Thank you very much.
Great. Thank you so much to our clinical colleagues for taking us through that in such a clear manner. And it's really exciting to hear of the work that's going on in the 3 models we've heard from. The board has actually now heard from 5 different models of care in the last 2 weeks. So we're nearly halfway at hearing from our clinical leaders about what's going on. And I don't know about you, but I'm really excited listening to what we aspire to achieve over the next year. And I'm sure colleagues would be happy to take any questions, Chair.
Yeah, can I just say, tremendous thanks for what you have done, and you and all your colleagues. It gives great pride to be associated with CCAM, and your innovation and commitment is really, really commendable. And it's, for me, it's the strategy coming alive. It's about transformation and how we are really focused on delivering the best for patients. But can I open it up to questions from colleagues or comments? Simon, you wanted to say?
Can I add my thanks? Firstly, great presentations. I mean, I just thought fantastic from all of you, really. So much appreciated. And thank you for being there, Julia. I mean, I know you're sitting there very quietly. That doesn't mean... you may want to answer this. So I have 3 things. 1 comment, 1 question and 1 challenge. So the comment, first of all, I'd invite the board. I think this is a really important, as Michael said, part of our strategy. So I think we should invite them back during the year to hear how these stories develop, because this is an ongoing effort. That leads to my challenge. One of the things we've been talking about and will talk about as a board is measurement. So if I was to invite you to think, if we were looking at this at the end of the year, what would be the measurable difference? You don't have to answer now, but what would be the measurable difference that you would start to point to? Dan, you gave us the most in terms of measurement, but my question for you, my challenge for you is, your slide on health inequalities was very compelling, wasn't it? Because it is actually the starkest difference about measurable outcomes of difference for people. But I noticed on your aspiration slide, you didn't really touch on what could we do in the year ahead to start to chip away at that health inequalities. What place could we go to start to change one of those kind of darker shaded areas a little bit lighter? Because maybe we should be thinking about, how do we get into an area with more public access to defibrillators? How do we try and promote some of those volunteers? And you were talking about it much more eloquently than I can. And I just think we need to think about that too, because that's something that is of the most visceral difference to our patients. And then the question, what support do you need from the board? What support do you need from us to help you be successful in your year ahead? You don't have to answer now, but if there was anything you did want to flag, that was my 3rd thing. Thank you.
Yeah, thank you very much, and I commend the presentations just now. I think they're fascinating, and I do also want to thank Andy, who brought this vision through the strategy almost 2 years ago with the work David did, so it's great to see it live. And I could have comments for all of them. Falls and frailty are very close to my heart, but end of life, I just got a question here, Jem, which is, we talk about systems, and for nearly all the models of care, we understand that that's a lot of multi-agencies. But for end of life, of course, it's primary care who have that umbrella over all of the patients in that cohort. And many of the patients only have that touch point until they get to that emergency care situation. Many of whom don't, but the majority do. And yet primary care is the partner in the system that is absent very often. So when we go to any of these provider collaboratives, when we go to any of system-wide meetings, primary care is often absent through various reasons, but they are often absent. And I just wondered what you're thinking, having many touch points with primary care, I know through your multi-jobs, what your thinking is around how we can manage that, because that's probably more unique to end of life than to any of the others.
Thank you. I think it absolutely has to be part of this system solution, and GP surgeries will often or partly rely on hospice responsive services to come out, but we all know their funding's been dropped and services have been cut. community nursing equally under pressure, and patients end up going around in this circle of not knowing who to call. So primary care absolutely needs to be part of this conversation, but it needs to be everyone together. And we're starting to see that through some of the ICB work and trying to pull everyone together to get those solutions. But charity partners, I think, are going to have a bigger part to play in this model of care than potentially others. But you're right, primary care is going to be my biggest challenge.
And I just wonder whether that's going to be a little bit harder this year now with the pressures in the ICBs. Because really the ICB are the main representatives of primary care. We rely on them in those forums to talk on their behalf. Very often you still don't hear it, but nonetheless. So I just think that's something we need to be cognizant of. And maybe when you think about what support we can give to you, you could, be focused on that as well.
Thank you.
My question was around the falls section. Just checking my understanding. You alluded to partnership with community, and my understanding was that there was a very successful pilot with Sussex Community that the ambulance service called them and they would attend, and that was a successful process which is continuing. Is my understanding correct, or has it stopped?
In regards
Where are we
to
with Sussex Community in terms of our partnership?
Yeah, so there's a huge piece of work ongoing with regards to how we work in collaboration with our partners in urgent community response, and that is across the whole of the region. Very much Sussex as an ICS was kind of at the front of that, and that has been enabled through. Initially, we had daily touch point calls with our colleagues across the three and a bit our ICS systems, whereby once a day they would have a call with us. We would share the waiting stack for all patients with lower acuity needs, and colleagues from urgent community response would say, actually, that patient there, it's something we can very much respond to, and we push it out of our stack to them to respond instead. That's now moved and is continuing to move towards a much more efficient system through what we call Portal. So this is an electronic portal which very much sits alongside our clinical validation processes. So at the point that we review a Category 3, Category 4 call, we can put it into an external portal for a 30-minute period, and the local urgent community response team can review that. So they see all of our triage, they see all the notes that we entered during the call, and they have that 30-minute window to automatically pull it out of our CAD for them to respond instead. Across the region, they're probably at different stages. So very much Sussex are probably the furthest ahead with that. And daily are responding to several Category 3 and 4 calls, a lot of whom are patients on the floor and have fallen. Surrey is very closely behind them, and there's a lot of learning from Sussex supporting Surrey, because it's a very different way of working. Responding to a 999 call as a community provider feels a little bit uncomfortable to some people. So we're actually, as a trust, we're supporting that sharing across the integrated care system. So in Sussex, we're saying it's okay, actually, that most of them aren't big sick. Most of them don't have big injuries, and you actually can. And so we're building Surrey's confidence through Sussex. Kent is a little bit further behind, and there's some real important work going on in building those relationships with Kent, and getting them on board on that journey as well.
Thanks for the question, Martin, and thanks for the very good response details from Jackie. Would you like to?
Thanks. A couple of observations, if I may, and forgive me if I'm stating the obvious, but I think they're important things to say out loud. I think there's a couple of really kind of big shining jewels in our crown here at CCAM, and I think one is the approach that we're taking here by, if I can borrow, Tom, from your QI kind of language of actually looking at the problem that we're trying to solve, understand it in real detail, and then apply solutions to that problem. And I say that because often organisations might attempt to apply a solution to a problem without fully understanding it. And the approach that we're taking, I think, has got a high level of success for that very reason. And the other jewel that I just want to highlight actually is the quality of the clinicians that we've got leading this work. We've got a fantastic group of specialist, advanced and consultant clinicians here that are able to drive it and apply the real expertise that we need to make this a success as well. So I just wanted to sort of make those observations.
Thank you very much. The points very well said and have the full support of the board. I think really, really spot on. Thank you.
Thank you again, echoing very inspiring presentations. It always makes me want to get involved as a clinician myself, so that's very good. Thank you very much indeed. I look forward to hearing how it goes. I've got a comment generally around the Falls work, if I may. I had the privilege in the past of being involved in some research into reducing fall rates in hospital, and I think that also puts it into context. In getting people into hospital isn't always the right solution, because if you look at the amount of money that's spent by treating patients that fall in hospital, that's not the right place for them either, which you're well aware of. But I think there was something in that research that stuck with me around it was changing the attitude of the clinicians involved towards seeing falls as a diagnosis rather than a symptom. And I think that was absolutely critical. And I remember very vividly someone that was leading with the research would always invite the clinicians in the room to think, have you had a fall in this room? And most people would put their hands up. And then we would have the discussion about at what point does having a fall, do you have a fall and you then become a faller? And noticing how we start to label things and how that frames then what it is we actually do about it. So I guess I'm leaving that as a challenge for all of us to think about in terms of how we think about some of these issues and problems. My question really is for Julie, sitting quietly at the back, and maybe not for now, but I'm also interested, you've already made the point, a number of you, about how the health inequalities agenda plays into this. If there was one area, Julie, from your experience that you think it would be worth the board looking into further, what would that be? So I'll leave that sitting in with you. And just to finish, that it struck me listening to all of you how what really came through in your presentations is our trust values around kindness, integrity, and courage. And I noticed when we were doing the risk assessment in the BAF, one of the things we talked about as a risk was how brave the commission, these are my words, how brave we would be in the commissioning process or working with people to model, developing different pathways of care, and how we get that buy-in. And I guess that's a question for us, for the board, to keep under review. How are we doing that to try and get the support for the funding? Because I was very struck with the comment about what our non-commissioned work rates are now. And so clearly we have to think about that in terms of paying for this. Thank you.
Thanks, Karen. Really spot on points. I'll bring it out in the summary. But Liz, please.
Thanks, and thank you, everyone. And can I just say how tremendous it is to see clinicians leading our clinical strategy. And I'd echo Simon's point that we must have your presence at future board to measure our ongoing engagement with our patients around this. The question, and I think it's probably more for Tom, Julie and Jen, is do we actually have IT systems to identify these patients and our models of care? And how can we ensure, if we are referring to alternate pathways, that there's a safety net for those patients, that they don't then 12 hours later call us back and say, I've still seen no one and there's been no levelling of engagement? Or what, from an IT perspective, Cleric, etc., can Nick help you with specifically, as it's his first board meeting?
I mean, I can certainly comment on some of that. As I alluded to it in my presentation, is that for me, grouping falls, frailty and older people is a bit of an odd group together. With my background from a kind of EOC and 111 perspective and looking at things like NHS Pathways as our triage system, for me that's the core to identifying that cohort of patients. which is really difficult for this group of patients because they're not labelled as fallen, because they've fallen and they had a fainting episode, or they fell and they have a leg injury. And when we actually started doing a little bit of QI work around that, we went, this is actually really challenging, because when we looked at the CAD and we looked at the triage, there was actually a really small number that were coded as fall. But when we then dug into that a little bit deeper and looked a little bit more intelligently at how we could look at the data, we went, blimey, it's about 4 or 5 times the number of patients. So you're absolutely right that we really need to work with our colleagues in data and performance to, because we know what we want to do with these patients, but I would argue at the moment, particularly for probably mine and Jen's, we don't really know who they are, and we don't really know what we're doing with them. So as much as we want to aspire to this as the end goal, we need to understand that bit before.
Nick, very briefly, I know you've got
Yes.
this in your sights, but please.
Thank you, and I must say thank you to for all 3 sort of summaries. It's been very educational on my first board. I mean, from an acute background, the acute hospital world is much more integrated in its data, so it has a greater visibility, and it's something that's been worked on very hard over the last few years to get that level of integration, and we can definitely build on that. So what I've seen in my first month is that we currently have much more visibility of when patients have been to us before than when they've been somewhere else. And one of the steps that we're taking to help with that is a National Care Record System access, which I think will help because it'll give us visibility of what journey that patient's been through elsewhere. So that's the first thing, and that's absolutely something that we are starting to put in place and will become more available. But we need to think really about the use cases of how we use it, when we use it, where it will add value. So that's something to do some work around, not just the technology, but how we use it. I think the other thing that strikes me is we have lots of data, but we don't always know how to construct it together, the different data sources, to make decisions and to pull the right information together. So I'd really value your thoughts about where you think we have points of data that we could bring together to construct useful information to make decisions, and where you think that data's lacking, where could we find a source to collect that data from so we can start to use it? So let's continue the conversation. I think that would be really, really helpful. Thank you.
Okay, I hope by the level of questions and support you realise that we're 100% behind you in this, and looking at Janine, I think one of the big changes, I think we've been here the longest, haven't we? I don't know. What I see is a real shift in the thinking of CCAM. We're becoming clinically led, and that was what the whole emphasis of the strategy was, and I think that's a real great achievement. And what I'd also pick on from my previous experience, in the past, digital and clinicians have not always spoken, and I think it's really, really important that your needs are reflected in our digital strategy and how we move forward. So thank you for that. And the final point I'd say is, Janine, we're relaunching, aren't we, our charity as such, and it did make me begin to wonder, seeing your brilliant slide on, well, not so brilliant, on inequalities, how far we might begin to think about our charitable arm. I don't know if it's within our constitution or whatever, to help support some of this. It might give a new focus going forward. So I'll leave that to you. Anyway.
Yeah, it absolutely was going through my mind when colleagues were speaking. I will be sharing with the board more initial ideas of the 3 pillars that I feel could drive our strategy moving forward around supporting our staff, supporting our volunteers, but also supporting community and school engagement in its broadest sense, which actually would particularly touch on Dan's, but would also touch on the others as well. So I think there's some real opportunities as we move forward.
Thank you, and I know you'll take that forward. Anyway, thank you very much for your time, and thank you also to Richard and Andy for making this possible. I'm conscious that I'm probably sharing this badly because we're behind time, but I make no excuse for that because I think the issues that we've been talking about are core to what CCAM is about. So I'd like to break for coffee or tea come back in 10 minutes. And the last hour of the board will be very much focused on, we've looked at the future, what we're doing, our agility. The last hour will be very much on our current performance and what we can learn from that and the level of assurance. So could we come back in, what time is it?
For 12:05.
12:05. Thank you very much.
Oh, she's come back. So share. See what she does with it.
Yeah. Sorry.
It's good, isn't it? No, we have until we press the button.
Right, could I reconvene the meeting? So really great everybody's back on time, thank you. We've got 55 minutes. The next part of the board meeting is really much around current performance, and we look through the integrated report. Could I ask, we've got 55 minutes, I'd like to do broadly 20 minutes on each of the key components, quality, people and partnership working. So I think we start with quality, and it's over to you, Liz. You've got your really excellent report. Anything that you want to particularly highlight? So thank you.
Thank you very much, Chair. And in the interest of time, obviously we've already covered some of the areas that the QPSC committee looked at. So again, similar to Howard, again, alert, assure, advise. Just to alert, we've covered the models of care, just that level of assurance that the committee, this is a key focus for us alongside virtual care, fundamental to our strategy, and we will maintain that focus throughout the next 12 months on this. Excitingly, alert clinical supervision is around our paramedics actually having the rollout of this. The aim is by the end of Q1 to have the final processes in place with rollout from Q2. And thanks to the work from Andy that's been done on this, we are aware there are a number of risks, particularly around the time required to deliver clinical supervision for our people and the impact that could have on operational performance. But we were assured that this would be managed, but we will seek ongoing assurance around that. In terms of the integrated patient safety report and the learning from deaths report, just to say we have got a focus on driving standards following, it's a theme on our risk register and was a focus of our recent board story, and this now comes under Jackie's CPO remit as well. Equipment, missing faulty equipment were reflected in the risk register, and then we looked at discharge on scene. As we've heard early, we are looking at less conveyance of patients to hospitals, but also a level of assurance that we're keeping our patients safe and that there is follow-up if we do discharge on scene. And there's been a pilot of that work out of Tangmere, so we were following up and auditing that that clinical decision making was appropriate, and then follow up and feedback to our crews out there. We discussed our Q1 priority, safety in the waiting list. Everybody is aware, I believe there was a QI project in January last year around actually keeping our long wait patients safe in the stack, and that's our C3 and C4 calls. And I think this highlights around how we can still care for our patients, but in a more efficient management way from our clinicians. So the implementation of interim care advice, automated text messaging, and these improvements have supported more than 1,000 hours of resource being given back to both clinical and non-clinical teams. And I think that's staggering for what was a relatively small piece of work, but took a long time to get absolutely right, but allowed an increased focus on patient care and those most critically unwell, and efficiency savings based on that baseline period equates to over 200k. So significant amount of saving from that work, and we now know other Trust and Blue Light services are following our lead in the use of text messaging. And you think in 2024 we'd only started using text messaging to our patients who are waiting. So well done to the team on that. We did a clinical review of an NHS.net BCI, and we've now closed that down as it is a much wider system issue around NHSNet, and I know that Stephen and Nick are very aware of that. And in terms of advising, it was around our health inequality, steady progress being made, and we're looking at further implementation through our quality accounts to make sure that we move those areas forward, particularly for our maternity patients and our mental health patients. And then lastly, our focus is on our patient care records and to improve the quality of patient care record completion and support meaningful supervision to our colleagues, which then links back to our clinical supervision. So I hope you've seen the thread from the strategy from the back through to the quality committee, but I'm very happy to take any questions.
Liz, that's excellent. Yeah, I do see the link, and that's very good. Before I open it to questions, I'd just like to ask Paul, because I know there are operational aspects that you look at, particularly around deliverability, if you wanted to add anything to what Liz had said.
No, not really. I think we're very aligned, actually. So I think I've never seen such an integrated plan ever as what we've got now, actually. So we all fully understand the strategy. The threads from the BAF are flowing through everything. You know, in now it's just a matter of what we said earlier, which is how do we actually best support you? Because I think the quarterly reviews that you discussed were brilliant. You know, and I think as a board we can be more supportive. And how do we really behave differently to do this support and focus more on the patient, so and using data more effectively. No, so we're delighted with where we are. We have got a lot of challenges though.
Okay, thank you very much. And could I ask Richard, Margaret, or Jackie anything you want to highlight to the board in terms of patient quality and the assurance that you can give?
So yes, I think it'd be worth just reflecting on the maturity of the committee itself, and certainly I know Richard wasn't able to join us last time, but Jackie and I reflected on the fact that our NEDs provided a great deal of support but challenge as well in a way that was very constructive and enabled us to have really constructive challenges across the piece, so we could feel more integrated and linked as we brought in different areas into all those headlines Liz has just skimmed over, because it was a very detailed meeting. We did have CQC in attendance, and the feedback we got from that was extremely positive, that they could see that the patient's story, the patient care and the safety of patients was integrated across. They couldn't see any cracks between that in the conversations. And for me, that's probably one of the greatest compliments that could be given. But I just wanted to state that we are feeling that increased level of scrutiny and challenge, which is good. It's good for us. It keeps us on our toes, and it keeps us sharply focused on our areas.
Okay, thank you. Any issues that Richard or Jackie?
Certainly no issues to raise specifically for the attention of the board today. We did discuss at the committee that we changed some of the timelines for supervision to make sure that we got it right, because we had some implementation challenges, and the committee were very supportive of us tweaking things a little bit, importantly, to get the supervision right rather than chasing a time frame which perhaps was a little bit tighter than we'd imagined. That's probably the only thing.
It was just to build on the point that Liz and Paul mentioned around, I think, one of the things that we're really maturing through our board development programme is the integration of the way that we work through the committees, and bringing that up to board and teasing out the kind of key interrelationships. And you both referenced the relationship between the quality of the care that we provide and the operational kind of inputs and productivity requirements that we need to meet as well, which is a really important relationship. So I think it's absolutely correct to say that there are some operational implications for doing things like clinical supervision and also post-discharge reviews. Those are significant asks of the time of our frontline clinicians with valuable outputs. We're probably better at understanding what the impact of the input is than maybe understanding the input of the output. So the safety improvement that can be generated by post-discharge reviews, the enhanced clinical practice and effectiveness of our care that may be delivered through clinical supervision. We're less mature, the NHS is less mature, it's not a CCAM thing necessarily, at understanding, measuring and making the proper value of those outputs. So we tend to see the input and not the output. And I think that is a risk, because it may be we don't value the work, but it may also be that if the output isn't what we anticipated we don't know, and we can't then go back and change. So as we mature that conversation and the way that we measure both inputs and outputs, I just wanted us to be conscious of that point, because we're trying to balance a limited resource set of inputs to get the right outputs, but to really know that we're getting them and be able to measure them in the same way as that 200,000 that's been talked about in terms of the safety on the waiting list. It wasn't necessarily that Simon B got £200,000 to like put in his pocket. It's that it's more of a productivity improvement that enabled us to meet higher demand within our EOC setting. So it's a productivity improvement that's really measurable, and we perhaps need to do more of that and describe it in those productivity terms.
Thank you for that. I think the whole, and we talked about it, the whole concern about how do you define productivity in a way that is meaningful is a real challenge going forward. But I take all of that. But David, please.
I was going to make a very, very, very similar point than Jen. No, that's fine. And never letting you go ahead again. No, I think an example of this, and I think this is where, back to your question, Paul, of what can you do to help is, let's grow complacent now, and let's take that as the next challenge, because, and Jen is still in the room, which is excellent, right? Because we've got end of life, and Jen has been talking about non-commissioned work, and we know that it has an impact on productivity of our people who are out there, and we have very intentionally distinguished our plan this year between £10 million of efficiency and productivity. So I think, through the work in the committees, let's try and challenge ourselves to get there, to say, if we get the end of life care model right, what does that mean by way of the productivity that it releases, and how do we close that circle of being able to say, actually, a more productive model of care overall is a safer model of care. Those two are not separate things, and I think we need to really step into that space of understanding a more productive way of delivering care, as delivered through our models of care, will deliver a safer service overall and better outcomes for patients. So I just wanted to make that connection as well.
Thank you both for that intervention. But can I ask any questions of Liz from other NED colleagues, or are we broadly assured around the quality of care that we are delivering at the moment? I assume no. So that's quite good. Well, more than quite good. Excellent. So typical British understatement there. For my apologies. Can I now then go on to Max and people enjoy working at CCAMS, the whole how we are supporting our.
Yes, thank you very much, Chair. So 15th of April was obviously my first People Committee as Chair, and I'm looking forward to working with colleagues to evolve and enhance the People Committee. A number of colleagues will cover a few of the topics that we discussed during our meeting shortly, namely education quality, the staff survey and shadow board, so I'll not preempt those. For the remainder set out in the report under alert, we discussed and welcomed the alignment of the corporate restructure and divisional clinical model. We emphasised the need for organisational and leadership development to be baked in as it is, and wanted to see clear goals identified and tracked and reported throughout the progress of that.
We received an update on the culture improvement journey and related live issues within Salt and Heart. We underscored as a committee the need for PACE to see a plan, improvements, and maintain a key eye in terms of seeking assurance on improvement on this area. Under Assure, Sarah shared with us the report on the HR improvement plan and progress over the year. The committee was pleased to note the achievement across all but 2 areas and a plan in place to address the remaining. Most powerful, however, was to hear from exec colleagues that green shoots of improvement were being felt in the organisation as well. So broadly assured that that work is on track and looking forward to seeing continuing progress in this area. We also discussed the health and safety internal review findings, particularly those themes and locations that need specific prioritisation and focus. We're reasonably assured with health and safety compliance, but definitely see more to do, and an ambition to move from health and safety maturity of 3 to 5 is shared by the People Committee. And that is out of 5, so from 3 out of 5 to 5 out of 5. And in terms of IQR, the people metrics are broadly stable or heading in the right direction. However, appraisals and mandatory training compliance remain a key focus. That's probably, I'll pause there before we go on to the 3 supporting papers for any questions or builds from other colleagues.
Thank you, Max. Are there any questions of Max at this point? Can I ask Sarah just one thing that compliance, I know this is always, and we get, are you confident we're going to make more progress with staff appraisals moving forward, or and also compliance with mandatory training, because clearly this is something that that we are held to account for as a foundation trust.
So thank you, Michael. We continue to put in a lot of work and effort around not just the number of appraisals, but also the quality of the appraisals that take place. I think there are still issues with the quality of data. So more appraisals are taking place, and we're looking at the data quality around that. So we're confident that we're on an improving trajectory around that, and we'll continue to do that. And I know with Jackie's support, because obviously that the learning and development statutory and mandatory training is going across to you as Chief Paramedic, and you put a plan in place that can build on the work that's already done to improve those statistics over the next year. So I don't know, do you want to add anything, Jackie, to that?
Probably just to echo, we are seeing a improving trajectory, but there is loads of work that's being done to improve that, both from the point of view of the quality of those conversations and the reporting as well. We do find the reporting approach is a little bit clunky. There is a pilot in place to try and make that a little bit easier for people, but it's absolutely a really important piece of focus for the L&D team over the next 6 months.
Okay, and just building on that, I know a lot of work is going on, but the management and development training, does that include a component that helps our people understand how you do appraisals? Because I agree with you, the successful appraisal is the one that really means that both individuals come out of that feeling that they've added, that it's a positive experience. Even where you're questioning performance isn't as good as it should be, it's a learning opportunity. There's a big skill in running a performance appraisal effectively, and are we equipping our middle managers, our leaders to be able to do that?
I think it's an area which is a bit of a gap for us at the moment.
Okay.
It does. Someone's at the door. It is a bit of a gap for us at the moment. We need to undertake a bit more kind of training needs analysis work to match up what staff need versus what they're getting at the moment. So it is an area.
Could I ask that,
for further work.
For Max's committee, that we come back and give us some more assurance on that over the next 6 months?
Yeah,
thank you. Thanks, Max. Thank you. Okay, Jackie, I think the next paper is yours, isn't it, on medical education quality intervention?
Thank you. I'll turn my mic back on. So I'll take the paper as read. The board will be aware that the NHS Workforce Training and Education Quality Team visited the Trust last year to undertake a review. That review was on the back of a national piece of work. as part of the review, 277 learners that have got a relationship with the Trust from a placement point of view were interviewed, and many of them said many positive things about their experience with us, but we did learn quite a lot of things from that review in relation to what we need to improve. We heard that some learners had some bad experiences in relation to supervision, both in terms of access to practice supervisors and the experience with the supervisors themselves. So that report was published in December last year. They provided us with a number of recommendations related to the issues that I've just summarised. We've put an improvement plan in place to address those issues. The improvement plan is, as we say, a bit of a living document. So this is something which will outlive the particular actions that we've got here. We took that to People Committee, as Max mentioned, just a few weeks ago. The education team have also been back into the organisation since they asked to have a senior leadership conversation with us, which they did in February. They're just in the process of providing us with a report from that conversation, but it's fair to say that conversation did go quite well, and they sort of fed back to us that they had a level of assurance that as a senior leadership team we were aware of the issues and we were acting on them. So there's a summary report in the pack which is intended to provide some assurance to the board that we're aware of the issues that have been raised. We've got an action plan in place to address them, and at the current state the action plan is up to date. We're making good progress.
Okay, thank you very much. I've got a few questions, but I'd like to open it up. Any questions from colleagues on this? Karen, please.
Yes, thank you for that. One of the things that came up in the review, and we've spoken about since, is around the involvement and the relationship with the universities. And it might be helpful if you said a bit more about how the work's going on that for further assurance. Thank you.
Yeah, that's fine. One of the things which we do need to improve on is the level of communication that we have with universities when a concern is raised about a learner that's on placement with us. So at the moment we're trying to sort of negotiate with negotiate might not be the right way, we're trying to liaise with the universities and internally to try and work out what the right process might be. So what we don't want to do is set up a process which our university partners can't respond to as quickly as we might need to, but we want to get them more involved in at the earlier stages so that they're able to take a level of assurance themselves that we're taking adequate processes to protect an individual learner. But what we also need to do is get a bit better at how we provide assurance to our university partners that the overall placement itself is adequate. So moving away from focusing simply on the individual issue that we're faced with, but also the wider issues that might be relevant as well.
It's a question for you and Sarah. So for those of us who've been involved in their executive career with, having a big workforce that is undergoing training, the transition from qualification into that first frontline job, it can be quite difficult, and it's important that we get regular feedback from them of what their experience is like. I know we have the people survey, and forgive my ignorance, how do you keep, it's the student voice, how do you get that? Is that sufficiently well organised for people to give us feedback on a regular basis as to what it's like to be paramedic with your first job in CCAM?
So we have a number of routes of feedback that these learners are able to take. So the first thing is there is a National Education and Training Survey, which is run by NHS England. It's got some similarities to the staff survey, particularly in terms of it happens at a similar time of the year. That's just been published, and we're just reviewing the findings of that. So that gives us insight into the experience of people that are on typically university programmes, so your pre-registration paramedic students, for example. We also have internal survey processes, so we do regularly take feedback from our learners, whether that's a very experienced paramedic on a key skills course or a learner as part of our newly qualified paramedic preceptorship pathway. So we do get that feedback in both a qualitative and quantitative manner.
Sorry to be challenging. Have you ever asked them
ask the paramedics if they think that's sufficient. So the national survey, we tend to rely a little bit less on the national survey because it gives us a snapshot into one particular group of learners. It doesn't give us a snapshot of all of the learners. And we tend to have quite small figures in that. So it's a really important information source for us, but it's not the only thing that we look at. The predominant thing that we look at, and we draw the national stuff into that, is what our learners are telling us about our educational programmes internally. So, for example, we've just launched the Key Skills programme for quarter one. That's the sort of mandatory and sort of practical training that all of our clinical frontline staff need to do. And the first thing that happens at the end of that first week is, collecting in all of the feedback that learners have provided, so that right at the beginning of it, if there are things that learners are saying, actually, you could tweak this, you could tweak that, we've got an opportunity to put that into place.
Just making sure they feel wanted and looked after, which is so important. But thank you for that short.
Yes. Next two from me. I'm going to kick off, but I'd just like to say I've got some of my team to join us today. They can't all be here, unfortunately, because actually both of the next two papers are A, down to their hard work, really, and B, I think, really demonstrate the really significant shifts we've seen in the organisation in the past year to 18 months in terms of culture and engagement. So I thought it was fair and nice to ask them to join us as well today. So
Thank you so much for coming today. I don't want to embarrass you, but could you just say who you are by just your name? That would be wonderful, actually. Thank you.
I'm Rich Carey. I'm Tom Badger.
Okay, welcome.
Hi, I'm Susan, and I'm the Employee Engagement Officer. And I'm Emma. I'm the Communication Officer for Sussex.
Okay, well, thank you, and I'm really grateful for all that you've done. And I know we're not going into detail. The last week has not been the easiest week for, so thank you for your perseverance and all that you've been doing. So, Janine, grateful for you bringing colleagues here today.
thank you. So I'm going to start off with the staff survey. Mindful of time, but I will focus on the response rate, the results, and what we're doing with those results, just to take us through. So after quite a long build-up, the results were finally published on the 13th of March nationally, and at that point we got the full set of results, which included how we compared to our colleagues nationally, which provided an additional measure, really, in us gauging the progress we're making. So on the response rate, our response rate, 67%, as a reminder, was the best the Trust had ever had. That meant we heard from 3,300 of our people. We also compared really well to the sector average, which for our ambulance colleagues was at 49%, and which had gone down compared to last year. So A, we had improved our own response rate, and B, we had also kind of bucked that trend, which had seen other colleagues go down. In terms of the results, obviously we've shared these really widely, so all colleagues are able to see those. But actually the key headlines here are we saw significant improvements in every one of our 9 key theme areas, and we were above the sector average, well above the sector average for all of these, and actually, as Simon mentioned earlier, the top performing trust for morale, for the morale score. Probably worth saying at this point, we know that the ambulance services nationally don't perform terribly well in the staff survey, towards the lower end of the scores most definitely. So actually being towards the top of that grouping doesn't mean we are doing as well as some of our colleagues in the wider NHS. And that's where our aspirations are, most definitely, to push that forward. But I think it's also important that we are realistic about the improvements we can make, so that peer comparison is meaningful, and we need to recognise that. The key headlines out of the survey where we saw improvements were around care of patients, recommendation for the organisation as a good place to work, and feeling safe to speak up. All really key, part of our strategy, part of a focus of our plans during the year. So really good to see the work that's gone on reflected back from our people in them telling us that. I'm going to touch on here as well about unwanted sexual behaviour from staff, a really hot topic. We know as a sector this is an issue for all ambulance services. We know that it's an issue for us as well. We saw a really small improvement in the scores there. Not as much, I'm sure, as we'd have wanted, but an improvement nevertheless. And actually, I think it's also important for the board to note that actually we performed best out of our ambulance colleagues in that area as well. So, one incident is one incident too many, but actually I think sometimes when it's an area we're really focusing on, we tend to think that we have more of a problem than other colleagues, or it's more of an issue for us. Absolutely a problem, but actually we are making progress, and that was reflected back. We saw three areas, three specific questions where we saw some deterioration compared to the previous year. 3 out of 100 odd questions, but 3 nonetheless. And 2 of those were colleagues reporting discrimination on the grounds of ethnicity and on the grounds of gender. So we have already started to look into those at a more granular level, because what we can see through the results is actually that's not a consistent picture across the whole trust. There are some real hotspot areas that are affecting those results. So we'll see, later on in the pack, you'll see that data has already been fed into our EDI plans, the residence data going in, and what we need to do is understand that more. The third area where we saw deterioration was staff experiencing physical violence from patients and service users. Not a surprise, I would think, and was reflected in all ambulance services seeing the same. But actually a good reminder from us that this is something our staff are facing every day and are telling us they're facing every day. So we had these encouraging results. We had a good response rate. What we've been focused on really since the start of the year is what we're doing with that data. So we've taken a dual approach this year to make sure we are absolutely making the very best of the feedback we've had from our staff, and we are telling the organisation what we are doing with that data. So at a local level, we've carried on the same approach that we took during the response phase, which is to work with our managers for them to own and use their results to drive improvements locally. And I'd like to say particularly the response from our operational managers this year during the response phase and using the results has been very different in a positive way than we've seen before. They are really owning their own results, and we look forward to seeing, as we touch base with them over the next few months, what they have done with those results, how they've worked with their people to drive improvements. At a corporate level, obviously we'll be using the data in our EDI plans. I know it's feeding into Sarah's HR improvement plans, but we also tried something new this year through an exec triangulation exercise where we used our staff survey data. We also brought ER data, complaints data, patient safety data, and looked at that in the round in a holistic way as a prompt for us to ask curious questions as to what was that data telling us in the round. I think previously we have looked at data in silos a bit, but actually this was the first time we sat down, each of the exec involved brought their own data, and we went through all of our areas at the areas that were standing out for us, where we needed to have those further conversations. So we are now working with the managers in a co-design approach to ask them what help they need from us, how we can help them, if they need our help or are they dealing with it already, but not imposing on them a solution, but actually working with them. Because Tom said it earlier on, the data is evidencing that actually we just need to have a closer look in that area for a number of ways. So that work started already. We'll be checking in with the organisation through the July Pulse survey. So as a sort of bit of a mid-year check-in on how things are going. And before we know it, we will be in staff survey season again come October. So happy to take any questions.
Thank you, and thanks, Janine. I always love listening to the results of the staff survey. I just wanted to bring the board to the attention of that deterioration in the sense of feeling violence and aggression from public and safety and link that to the IQR. Because if you were to look at the two things, they would seem incongruent if you thought they were the same times. But what you'll notice on the IQR regarding violence and aggression, so the incidents being reported, is that there certainly was an increase over 2024, which peaked, as we know, when we went into a civil unrest situation last summer. But we have got measures in place in providing support and tools, etc., for our staff, which came in the back of the Health and Safety Executive, which was in October 2023. And you'll notice on the IQR, because the reporting does fit with the storage staff survey, is saying that since we've brought in that extra training, since we particularly focused on that through the violence and aggression strategy, that the number of incidents reported since the staff survey would have been completed has been slowly decreasing. So we are now in the position of the least number of incidents being reported. We will keep an eye on that, and the team are very, very much focused on making sure the reporting culture remains as it is and in fact improves. But I just wanted to bring the board's attention to the two things. The staff survey was a point of time at the end of last year. Our IQR actually does reflect that, but it is also showing an improvement picture.
Okay, thank you, Margaret. Simon, you want to say?
I'd like to start just by, on behalf of the board, extending our thanks to the comms team. It's good to have you here, and just to acknowledge all the good work. I mean, I think ranging from the reunions through to the celebrations of excellence, through to the media stuff that we do, through to telling our story more internally, I think it's been a year of really great progress, and I think it's important we acknowledge that. So I just wanted to say that. I think two things really. One is I think it's going to be really important that we think more, both as an organisation and nationally, because while Margaret's absolutely right, we have a responsibility to train our staff. We also have a responsibility to publicly comment when behaviour is unacceptable by patients. That is also a responsibility of a board. And I know ACE have been public about the fact that this is not just an issue in CCAN, it is an issue right across the sector. So I think there is more to do there, is all I would say, because this is not something that is going to be easily solved, and it is quite pervasive throughout the sector, and it is unacceptable. I think I would encourage the committees to think about this. I think the triangulation conversation is really important. We're not going to get into obviously that detail today, but I think just suffice it to say culture, particularly in the ambulance sector, is not homogenised. It's very located, and I think conversations about how we support, and I think that is the key emphasis, how we support leaders who are often in quite isolated situations dealing with quite entrenched behaviours that have manifested over time, I think is a really important conversation. It's not necessarily one for a public board, but it is one that we need to have in a variety of our different committees to make sure that people are getting the support that they need. And so I'm just noting that here. And I think as we do our board development sessions with leaders in the future, we need to think about how we bring some of those elements into that conversation. That's all I wanted to say, but well done, team. Really great effort.
Thanks, Simon. Thank you very much. Can I ask any questions at all? Okay. Can I make a point, and it really builds on what Simon is saying. So the hot point, firstly, I think it's brilliant the way our people have responded, and a genuine thanks. If we've got the rate up at 67%, that's good by NHS standards. I have to be challenging and say I'm used to in other organisations it up at 80, 85. So we've still got some way to go, but that's not your, that's not your fault. can I just say this though, and it's really, really positive, but I've heard you say in previous years, Janine, when you've done these presentations, but there are still hot spots where behaviours are not acceptable and we're getting feedback. And I really echo what Simon is saying. It may be that managers are operating in isolated areas and it's difficult to deal with intransient behaviour. But actually, we have got to focus on this going forward. I don't want to hear next year, or I may not be here next year, I don't know, but I don't want to hear in years to come, we've still got these pockets. Yeah. You know, it's not acceptable. And, you know, I want that message to go out from me to all of CCAM people. You know, it's just not, you know, it's just not modern. It's just not part of the society in which we want to live. And I do recognise people need to be supported. But unless we actually focus on this, we won't make a difference. And it doesn't need to come to the board, but I do think you need to be presenting to the People Committee how we are seeing progress in those areas. And if we're not making progress, we need to do something about it. We need to call out inappropriate behaviour and deal with it. I want to support people, but ultimately people have got to change. Yeah. Otherwise, we will not get to the culture that we want within this organisation. Yeah. But it's really good results, and I'm tremendously, on behalf of the full board, as Simon, thank you for what's happened here.
I think the triangulation exercise we undertook was quite a different way of looking to address the very point you've made there, Michael. Yeah. We haven't done that in that way before. And actually, yes, that comes with support, but it also comes with consequences and accountability for those managers, which I don't think we've necessarily always seen before. So I think the evolution of our new structures and our new ways of working provides a really good opportunity as well, as the new operational divisions are born, for actually the restating of expectations around all of these things, really. I know Jen and others involved are really focused on the kind of OD aspects of building those teams to make sure they're right from the start. So I think there are some things coming together.
And I know you're with it. And the other thing I'd say is I don't want to go out there in the field and hear people telling me, well, it's just banter. It's not acceptable, which I still hear. And I don't think is acceptable at all, actually, on that basis. Anyway, thank you. It's a really good result. Progress again, excellent going forward. Yes, sorry, Karen, I didn't see you.
Sorry, if I may just build on that. All points well made. One thing I would encourage us to think about is, I think there can be a tendency, and I've noticed it in the NHS per se, that everything then gets located back with the management. And I would be encouraging us to build on this message that this is everybody's responsibility. And I had a bit of a road to Damascus experience many, many years ago when there was a particular pocket, the kind that we're talking about. And the leader got changed through various means over a course of 3 years. And then slowly the penny dropped that it was as much about the team. There's only so many votes of no confidence people can have in their leader before you start asking about the questions about what everybody else is doing in the team. So I think we need to look at both in the round, and I would encourage us to think about how we work together with the entire team, not just locating it all with the management.
Thanks, Karen. That's very well said, and thank you very much. Janine, your last paper, which is the Shadow Board.
Yes. So really excited to be sharing this with the board today. Did come to a People Committee, as Max has said already, but on Friday of this week we will be holding our first introductory session for our first ever Shadow Board. So I'm really pleased to share some of the detail behind that with the board today and what the Shadow Board are going to be looking at. We believe that introducing a Shadow Board in CCAM will absolutely enable us to hear different voices from across our organisation. That's been the key driver throughout all of our Shadow Board development. Provide that elusive link between the floor and the board, or help to provide that link that we always talk about. Add richness to the discussions we're having today. So I'm really looking forward to our next board, when we will have feedback from our shadow board to feed directly into the board. And also help the colleagues who are part of the shadow board to develop and progress themselves. Really excited about that aspect as well. We're partnering with an external organisation called the Inspiring Leaders Network, who are experienced in this, to help to support us with the process, recognising it's new for us, but also to make sure that our shadow board members are well equipped to participate fully in the opportunity they've got. And that's something we've worked hard on. Susan's here today. She's done a lot of the legwork on this, but actually that work to make sure it's meaningful for people has been worth the time and effort, I think. Just a reminder that the Shadow Board sits as part of our integrated engagement framework, so it's not the only way, it's one of the ways, but a new way that we're trying out. We launched applications for the Shadow Board at the beginning of March. I will say I was slightly nervous about how the organisation would respond to it. It's a new thing, you never quite know how people will feel about it, but we were delighted that we saw 63 applications from colleagues during that period, when we need 15 or so members. So actually really good response rate, real diversity from across the organisation. Lots of people we'd never heard of, which is exactly what we want. You know, this is about hearing different voices. Posed some challenges for the panel when we were reviewing the applications. Margaret, Max and Sarah had some input, and I sat down to review them. I think we were impressed with the quality of the applications. People had really thought about this and had thought about how they could contribute. But we had to whittle down those applicants to our actually 16 we've gone with rather than 15. And those colleagues will be meeting together for the first time on Friday. So how it will work moving forward, Shadow Board will meet 1 or 2 days before the board, varies each month, and we'll consider some of the same board papers that the board are considering, plus another, what I'm calling a sort of meaty topic that enables them to have something to get their teeth into that hasn't been through the committee and board cycle already, when actually, you know, a lot of the decisions have probably been made at the time something comes to the board. So it will be a real mix of board papers and then another topic that's come up as an area of focus through the staff survey. It's come up through other channels. Is something where we would really value their input and their views onto that. That feedback will then be, the feedback from the Shadow Board will be given directly at the board meeting, probably by Max as chair to start with, but over time by Shadow Board members as they feel more comfortable to come to the board and do that, which I'm hoping will be really, really powerful. So we start in April, the months when there's not a board. When we have our development sessions, usually there will be an action learning set to keep the momentum going, and to consolidate feedback from the board, etc. So really excited. We will wait with anticipation for the next board. Max, I don't know if you have anything to say.
Max, just to say tremendous thanks for chairing it, you know, and to give people as much confidence as we can. I know you'll do that, but in brevity, if you want to say anything, of course you can. But
yeah, thank you, Chair. And thanks, Janine. I agree, it's definitely a very exciting initiative. And I just want to echo your thanks to Susan and the team for the work to set it up. I think it's on not just those of us in the room for the Shadow Board, but also when the thoughts and insights and ideas of the Shadow Board come into this room, it's on all of us to create that psychological safety, that openness, that receptiveness to that forum as well, to set it up for success. So that's an ask that I posit for everyone in here.
100% support. Thank you, and that psychological safety, really, really important. So thank you to everybody. Really look forward to this. It's another way of hearing the CCAM voice, which is really, really important for us going forward. Last section, finance and investment. Can I say, Paul, what I'm going to do is just take your report and then Nick on digital, because I think we've had quite a lot of discussion around financing. Oh, Stephen, I'm sorry. Stephen, I apologise.
Okay, conscious I'm between us and lunch, so I'll be to the point. Right, so we had a very good thick meeting. In terms of things to be alerted to, we had we met the day after the financial plan had been submitted. And that was a lot of brilliant work from Jen's team and from Simon's team. And we've been through the plan a few times. It was very integrated and there's clear triangulation between operations, performance and the workforce and finance. So we're very pleased about that. We also, but we wanted to alert about how do we help in a calm approach to actually monitor progress, because it is very ambitious and very challenging, but there's great work we've gone on to get us to that stage. We also looked at how we were delivering our efficiencies, and again we've a further £10 million of efficiencies have to be delivered. So again, it's just how do we keep our tabs on that, how are we going on that. In terms of digital performance, that's also in the alert column. We'll talk about that with Stephen and Nick in a few minutes. At the moment, I'm very happy because we've got a CDI role's definitely proved its value, and at the moment I've got 2, right? But it is Stephen's last day though, so that's short-lived. Okay, and so we'll talk about digital in a minute. In terms of assurance, the team again have done a wonderful job at bringing us in on plan and also delivering efficiencies in the region of £22 million, which is a step change from where we've been. So we should really thank our finance team and the whole executive really on delivering that, which is unbelievable. It's brilliant compared to where we've been in the past, so thank you for that. We talked about operational performance and virtual care. There's a big topic, and I think that's going to be the subject of further review, but again, we feel assured that we're heading in the right direction and it's been very closely monitored. And that's before we've dug into even more detail, to be honest. So we were assured about that. We're also assured about the 111 contract that's currently up for discussion renegotiation. And again, we're confident that's been very well handled at the moment. The other areas about fleet performance, that was really in the advised category, because we've shown improvements over the years, but there's still quite a lot of challenges. Challenges in terms of retention and actually getting enough staff to work on and our off-the-road, vehicles are off the road too often. Again, we're going to keep an eye on that actually, but we're making good progress. So I think now we'll move on to the digital section and Stephen's report.
Yeah, thank you. And, there's a paper within the pack, so I hope you've had a chance just to cast your eye through it. What I was asked to do as preparation for this was to look about a year in review, coming into the organisation sort of part-time through March and then fully into to April. I think firstly I want to thank the exec colleagues and our SMG colleagues for the support to enable me to actually have a real analytical view on the organisation. Where did digital and data sit? What did we need to do to improve the performance that the digital service could bring, and what were some of the key outcomes? I think it was really helpful that the data team were able to provide me with insight and evidence to align my thinking, and then to drive the strategic review, so to design and build out a digital and data strategy, which was then ratified through this board in October of 24. I think some of the key recommendations have been taken on board, bringing digital and data together to create an outcome that makes a difference. Looking at our processes, especially in the digital services, I look at the service desk as a good example. Demands falling on that service desk based on the rollout of our new end user services, which is what one would expect, but the processes around that forecast demand and incident are just at their early stages. They need to be improved as we found. And we look at some of the outages that we had around the network over the last 3 years. Our processes fueled the outages. The fact that we didn't really understand what went wrong. We allowed change to be done in an appropriate way. We didn't have a design. So really to highlight that, which is something that's been put in place. Cyber, we were able to get the National Cyber Review. We as CCAM chaired that for all of the ambulance services, which gave us a pivotal moment to actually look at cyber in the round. From that, I've instigated a Go to Green plan that's been commissioned with a third party to enable us to work out how to resolve our cyber challenge. We're in a pretty good place, but to go from having some reds on our report to go to ambers and to greens, and that's already in place. I just wanted to kind of bring out a couple of other key points in terms of key programs. Some of them have been mentioned today. It's great to see that the strategy is being evolved. Things like using SMS to contact our patients. The amount of demand we've taken out and repeated calls coming into the EOCs. Quantified at 200k, that's a lot of avoidable cost. Not only allowing our patients to come back in and see where the ambulance is, but also for the patients to actually get a view on alternative pathways so they can cancel. So for me, the work that we did through the CAD, enabling SMS to be used in multiple factions has come through. National Care Record Service, as we mentioned today, about end of life. We didn't mention end of life, but it does give an end of life viewpoint. So if you've got a citizen that has an end of life care pathway, we won't try and resuscitate. The DNRs all come through that our paramedics will now get to see. So National Care Record Service, I think, is going to make a massive difference, and it will hopefully drive our performance and our job cycle times. So all in all, just to kind of summarise, I think the identified work that the team have supported me with, and they've done a lot of this themselves to get ourselves in a place I call ready for fit for the future. I think the groundwork's in place. It just now needs to be built from. So the foundations have been set. The house just needs to be built from the ground up. And I think the team that's in place are there to make it happen. So again, just really from a year in review in 5 minutes, Chair, just to say it's been a fun time. I've learned a lot, and I think hopefully I leave a legacy behind.
Steve, thank you very much for that. Very concise. Tremendous thanks also for what you've done. As you say, you presented, I think, the first, what I would call realistic and ambitious strategy for CCAM in the digital space. So thank you for that, and we wish you well going forward. May I take my prerogative as chair just to ask one question? I take all the work that we've done on cyber resilience and cyber assessment, but if you look at it from a Whitehall perspective, annually you do the compliance with the digital toolkit. That's now changed into the wider cyber assessment tool that has been developed by the Cabinet Office. We've seen what's recently happened at M&S with ransom and all that sort of thing. That we never stand still with cyber, and I was just wondering in this transition, how is the board going to get through your committee or audit? How is the board going to keep up to speed with our cyber resilience, because it's going to be so key in terms of our ability to deliver services to patients?
Yeah, Michael, a really important perspective that the board must have going forwards on that cyber resilience. And we've already, from the work that Stephen did in assessing our network environment and some of the weaknesses that we've had previously, we already in April did some major interventions to our front doors to the world, to our firewalls, and made some significant improvements to the security and currentness of the configurations of those, which is a big step forward for us. One of the things that I will be looking to bring back to the board when I do my sort of review of this year and the next steps to take, which I'll bring back in June, if I may, Chair, is something that I have done previously, which is a cyber maturity assessment. Now, I know Stephen led a thing with the ambulance service, across the ambulance service. That gives us a peer group of our ambulance trusts. It's actually quite a small group.
Yes.
And therefore, one of the things that I've done previously is to use a CIS framework, which is recommended by the National Cyber Security
that's what I used
Centre
to-
and NHS England. And that does a benchmark across healthcare and pharmaceuticals globally. And I'd like to run that exercise here, and that will give us a sort of spider diagram against our key areas of information security and resilience. And then that will give us a temperature check of where we need to make further interventions and where we're strong. And I think that's something that we can then use as a performance benchmark for the board to measure us on.
Okay, and it's building on both of your works. And again, that's for really Paul as our expert and Howard as chair of audit to take forward. So I'm really pleased with that. In the interest of time, can I ask, I know you were going to say something, but you'll be coming to a future board, and when you've had a bit more time, it would be very helpful for you to set out what your approach is.
Yeah.
But thank you. I really do take what you've said. You put the foundations in place, and we wish you well going forward. Unless anybody's got any questions around finance more generally and the performance, which I think we touched upon, Howard, please. Yeah.
Yes, it was just a general point or question around the IQR review and the hubs review.
Yeah.
I'm conscious that the IQR, I noticed the executive summary pages that have been introduced, which are really helpful, but behind that lies the summary of the KPIs. That page is much less helpful, I think, and where, as I've raised before, where there are no targets specified, the statistical process doesn't work properly because there are no tram lines and so on. So there are, in each of the three areas, there are some significant issues around not having targets, and therefore, where the process doesn't work. And I quote, just as an example of the quality of care area. In terms of the statistical process, there are no passes, there are 3 failures, hit and miss 7, no targets 15.
It's a very
Now,
good point.
there are circumstances where you don't have targets, and I totally understand that. But there are some areas there where we should be having targets, and for a long time now, we have not set those targets. I don't quite know why, but I think that is all part of the process review. I need some sort of comfort that that's in progress and will be presented, and a timeline, please.
It is a good point. We're slightly meeting in the foothills of the new urgent and emergency care plan, and I was alluding to that earlier on, which is going to set some new mandations for us. So it got delayed because we have local elections tomorrow, so we're not allowed to speak about it in public. What I can promise out is that what we will do is we will publish that to the non-execs as soon as we have it, and look again at the IQR and the targets that we need to report on, making it clear which ones are national priorities for the year ahead. There are some new ones. What the approach is not many, but those that there are absolutely to be delivered upon. Is that okay as a way forward?
Thank you very much.
I would expect it to be out, we were told yesterday at the National Leadership Meeting, in the next couple of weeks.
Okay, that's fine.
So we will publish it as soon as we have it.
Howard, well spotted, really forensic. And can we just record that as an action so that we take that forward? Okay, I've run over a little bit by 8 minutes, so my apologies. I just want to check there are no questions from the public or anything.
No.
No, thank you. Okay, just to summarise, I think it's been a really good meeting. I'm really grateful for the challenge that people have put forward. I think, drawing on what Karen said earlier, we have demonstrated CCAM's values of courage, integrity and kindness in the way in which we have approached today, so I'm grateful for that. I started by saying that this was the beginning and the end of a year, because I know when I was talking to Margaret, I condensed April into a year at one point. But it is an important point in our business cycle. So I think we can look back and be confident on what we have achieved, particularly in leaving special measures, the results from the People Survey, and real progress with the strategy. We know going forward we have got all what I would call the governance right to enable us to navigate our way through what is going to be quite a dynamic environment in the NHS. But we are, as an organisation, very much committed to patient care, the wider NHS agenda to improve productivity, and ultimately to deliver value for money and value to those whom we serve, namely the patients of our particular region. With that, I will close this, today's meeting, and thank you, and look forward to seeing you again, I think, in 2 months' time in our formal board. Thank you.